हेलो हेलो। We are live, sir. Over to you.
Hi, good evening, all my colleagues, friends, and students. Welcome to this virtual meeting, Best of ASH, which is 1 week long program from Monday to Sunday, 24th, 30th of January. This is day 2 of this webinar. This webinar is brought to you by Mumbai Hematology Group, managed by Mice Ideas. We have 3 lectures today. The first lecture is on long-acting antibody combination AZT7442 in COVID-19. This will be delivered by our friend and colleague, Dr. Dinesh Bhurani. Doesn't require any introduction if you have anything to do with hematology in this country. He's Director, Department of Hemato-Oncology and Bone Marrow Transplantation at the prestigious Rajiv Gandhi Cancer Institute and Research Center, New Delhi. Above all, he is a fantastic personality, a great clinician, and a great teacher. I can't go on describing his qualifications, but he is a personality by himself. This lecture is supported by AstraZeneca. I'm grateful to them. Second lecture is on chronic myeloid leukemia. It will be delivered by Dr. Andreas Hochhaus, who is professor at University of Jena in Germany. That lecture is supported by Novartis. Lecture 3 is on MDS. It will be delivered by Dr. Guillermo Garcia Manero from University of Texas MD Anderson Cancer Center, Houston, US. And that lecture is supported by Emcure. I thank Dr. Shweta, Dr. Drupad, and the team AstraZeneca, Mr. Rahul, Mr. Dinesh, Lekha, and the team Novartis, Mr. Keyur, Dr. Arvind, Manisha, and their team from Emcure, Rajesh Kalpesh and their team from Mice Ideas, Executive Committee of Mumbai Hematology Group, our 3 eminent guest speakers today, Dr. Dinesh Bhurani, Dr. Andreas Hochhaus, and Dr. Guillermo. All our discussants were themselves eminent hematologists and hemato-oncologists, and you participants for sparing your evenings after evenings. As I mentioned, this is second day, and this is Tuesday evening. Let me introduce our discussants today, and we have got a galaxy of them, very eminent personalities from various parts of this country. Dr. Hemant Malhotra, Director, Oncology Services, Sri Ram Cancer Super Speciality Center, Jaipur, is Professor and Head Department of Medical Oncology at Mahatma Gandhi Medical College Hospital, Mahatma Gandhi University of Medical Sciences and Technology, Jaipur. Dr. J.M. Kunga is Consultant Professor and Head, Department of Hematology at Vardhaman Mahavir Medical College at Safdarjung Hospital, Delhi. He was formerly Secretary of Delhi Society of Hematology and Vice President of Indian Society of Hematology and Blood Transfusion. Dr. Sandeep Shah is consultant hemato-oncologist and bone marrow transplanter in charge of BMT department, the Department of Medical Oncology at GCRI, Ahmedabad, Gujarat, and also at Hemato-Oncology Clinic, Vedanta Institute of Medical Sciences, Ahmedabad. Dr. Pranta Chakravarti, who is Director Hematology and BMT at Emory Hospital, is consultant hematologist, Vivekananda Institute of Medical Sciences, Kolkata Fortis Hospital, and senior consultant, Center for Digital Healthcare Technologies at McCott, ex-professor and head at NRS Medical College, Kolkata. Dr. Vivek Radhakrishnan is consultant hematology, oncology, and bone marrow transplant, convener immuno-oncology and Tata Precision Oncology projects at the prestigious Tata Medical Center, Kolkata. Dr. P.K. Jayachandran, who is Associate Professor, Department of Medical Oncology at Cancer Institute at Diyar, Chennai. Dr. Akanksha Garg, Assistant Professor, Hematology and BMT, Department of Medical Oncology at GCRI, Ahmedabad. Dr. Govind Patel, Assistant Professor, Department of Hematology, SN Medical College, Jodhpur. Dr. K.K. Radhika, Associate Professor, Department of Clinical Hematology at Nizam's, Hyderabad. Dr. Stelin Chaudhary Bala, Associate Professor, Department of Medical Oncology, Nizam, Hyderabad. Dr. Amita Chakravarti, Consultant Hematologist, Hemato-Oncologist and Transplanter at Max Hospital, Delhi. Dr. Rishma Roshan, Assistant Professor, Department of Clinical Hematology and Stem Cell Transplant Unit at the prestigious Sher Kashmir Institute of Medical Sciences, Srinagar, J&K. Dr. Aditya Murli, Consultant Medical and Hemato-Oncologist, Astra CMI Hospital, Bangalore. Dr. Ankit Mohite, Consultant Hematologist, Bone Marrow Transplant Physician, Jahangir Hospital, Pune. Dr. Deepankar Bhattacharya, Associate Consultant, Medical Oncology and Hematology, Medanta Hospital, Lucknow. And now it's time to introduce our chief guest for the day. And it's my proud privilege to introduce my friend, Dr. Shanaz Khodaiji. Once again, there is no one in this country who does not know her if you have anything to do with hematology. She's consultant hematology and transfusion medicine at the prestigious PD Hinduja National Hospital and Medical Research Center, Mumbai. She is president of the Indian Society of Hematology and Blood Transfusion for the current year. She was secretary of Mumbai Hematology Group. She has been the principal investigator of many in-house research projects. She has won several awards for presentations at various conferences, national and international. The recipient of BGRC Oration by Mumbai Hematology Group in 2009. She's the recipient of Manorama Sapre Oration by ISH BT 2019. She's contributed numerous book chapters and published articles in both national and international journals. She's organized several CMEs and conferences in hematology. Her areas of interest are benign and malignant hematology, flow cytometry, and molecular diagnostics. It's my privilege to invite her to inaugurate today's webinar and give us some words of wisdom. Over to Shanaz.
Thank you, Dr. Agarwal, for those glowing words. Hello, everyone. I have been attending these Mumbai Hematology Group meetings for years, for several years, decades, in fact. But never did I imagine that one day I'll be addressing you all as a chief guest. And for this, I owe Dr. Agarwal the honor. Now, I'm not quite sure what I'm going to say to all the young people out there today, because you seem much more poised and reassured and confident than I ever was. The reason for this is that your career path today is a series of planning. But for us from our generation, this was not so. We were not sure. In fact, once we completed our MD, we were not sure what we would do. As pathologists, most of us aspire to do histopathology. But today I consider myself extremely lucky to have got the opportunity to pursue hematopathology. I therefore believe that luck plays a very important part in one's destiny. Dr. Agarwal has said I should give some words of wisdom. Well, I don't really think I'm qualified to give advice, but I will just share with you a few things I picked up along the way during my journey of life. Now, one day we are all going to be much older. I know that seems very distant to all you young people in the crowd, but you're soon going, not soon, maybe after a long time, but you will get there. So what I want to say is that today we should work on minimizing the things that we are doing today, so that we do not regret it at that age. It is very important, therefore, today to give careful thought to all your decisions, whatever you decide. No matter how apolitical or non-controversial you are, there will always come a point in your life when you are in a tough situation and you are required to take a stand. At that point in time, you may be very junior, you may be in a minority, and you will be intimidated. In such a situation, taking a stand requires great courage. But I promise you, once you make that decision, you will feel so empowered and you will feel so liberated that it will be well worth it. All of us should learn to treat difference of opinion with tolerance and mutual respect. Life is a circle. What goes around must come around. So be thoughtful of your fellow human beings, which includes not only your friends and family, but your colleagues, and most importantly, your patients. Now, I have observed that it is important to have a plan in life, or else you always think, if I had done this differently, or if I had done it that way, I would have been better off. So some kind of plan or line of action. However, when required, this plan may change and you also have to change along with it. So you have to be flexible with that plan. Pay attention to the reality in front of you at that point in time, and don't stick to all the rules and regulations or the models that you have in your mind, which may be archaic for that point in time. In 20 years from now, much of what all of you have learned will no longer be relevant. So keep an open mind and, most importantly, be resilient. Name and fame are all very good, but apart from our profession, we also need to invest in ourselves. We need a personal life as well. There is a perverse culture in medicine where it seems to be a badge of honor to be sleep deprived, to work when you're exhausted, to work when you're sick. I don't think that's right, because you must take care of yourself, or else what good are you to others if you're not good yourself? Much has been said about work-life balance, but I've recently heard the concept of work-life integration, which I think applies a lot more to our profession, and which I think we should all strive to achieve. These are just a few stray thoughts, as I said, that I picked up along the way, so they might be disjointed, but I just want to share with you what I think. To the pathologists and physicians, I say, we need to work together. Teamwork is particularly important today because we are tackling very complex hematological problems. There is a huge lacuna in teaching today. We have far too many medical colleges and PG courses in our country and very few good dedicated teachers. Therefore, the knowledge that we imbibe from our seniors must be passed on to the next generation. This should be absolutely our professional responsibility. Fortunately, this is not a problem for us in hematology in India, because the stalwarts before us have laid the foundation for a cohesive hematology society. We have much to be thankful for having seniors and mentors like Dr. B Agarwal, who gives us every opportunity to grow and a platform to flourish. And finally, I'd say don't do it for the money. If you do things right, you will make enough money. The important thing here is to enjoy the process. And on a lighter note, motivation comes in many forms. We are all very motivated to attend our annual meetings and conferences, both of the Indian Society as well as of the Mumbai Hematology Group. But however, that added motivation for me is to meet all my friends who I have not met for over a year, and to catch up on the news and gossip. This is an added motivation for me to attend these meetings. However, we've sorely missed that over the past 2 years. Before I conclude, on behalf of the Mumbai Hematology Group, I would like to welcome the delegates and esteemed faculty to this much awaited annual event, Best of ASH. I hope that this meeting will be a rewarding educational experience for hematologists, oncologists, fellows, trainees, and hematopathologists. Thank you.
Thank you, Shanaz. What a speech. Absolutely fantastic. Thank you so much. All related words, very well prepared speech and beautifully delivered. I think it will have a huge impact. Thank you. And now, thank you. And now, Dinesh, over to you.
Good evening. Am I audible clearly?
Very well.
Okay. Today I have got opportunity to present a long-acting antibody combination AZD7442 in COVID-19. By presenting this, I have no mean claiming to be an infection specialist or the COVID infection. I'm thankful to Dr. Agarwal and AstraZeneca to give me this opportunity. I'm more interested because we deal with more transplants and more leukemia patients. So we can save our patients from this COVID-19 with a new methods apart from the vaccine. We will be interested. So I'm going to talk about this antibody combination. The most important part is the long acting, so it's not for a few weeks or a few months, and it's a prophylaxis also. Next slide, please. What we are going to discuss is the impaired immune function can lead to the increased susceptibility, the increased infection and increased burden of the COVID-19. So our majority of the patients, like all the leukemias, transplants, anyone who is on chemotherapy or the targeted therapies, they will be having an increased disease burden. At the same time, if we give a vaccines which have been very effective into the normal population, will have an impaired response. So because of the impaired immune function, the body will not respond, will not make antibodies to this. So if we have some additional protective features, if we can have something extra protection apart from the antibody, apart from the vaccine, definitely for our patients will be welcome. So considering we are going through the episodes of this epidemic, and it's like we try to make some changes, and then there is another variant, and we don't know what variant will be next, and how the things will evolve. So the many things are uncertain. The COVID has impacted our patients significantly. We have lost quite many of patients because of the COVID. We have delayed many chemotherapies because of COVID. Many of the patients could not go for the transplant at the time when the epidemic was happening. Next slide, please. So we have a patients which have immune function impaired, and that leads to the increased burden. I'll show you some data to suggest that's true. Next slide, please. In US, around 3% of the patients, the adult population, is immunocompromised in the terms of they have a blood cancers, or they are receiving acute chemotherapy, they are patients of transplant, dialysis, they are taking immunosuppressants, or they have a primary immunodeficiency. If you see, our patients also will fall into having a blood cancers. Most of them will be on the active therapies. We will be doing a transplant, and post-transplant they will be on immunosuppressant. So there are 4-5 categories. If you see among all the population, I think the hematological malignancy patients will be most affected among all immunocompromised patients. Next slide, please. Next. This is data from Israel after the vaccination. So there was 152 patients who were vaccinated, and then they were admitted into the hospital with a severe COVID-19 confirmed PCR. Among them, 40%, so there's a significant proportion, some will not be vaccinated or may not have a completed vaccination, but the people who had vaccinated, the 40%, they were immunosuppressed. Among them, the common causes was they were on steroids, like our patients can be. They had received anti-CD20. They've been on chemotherapy or anti-metabolite. So there's a significant numbers among the people who had been vaccinated. In spite of that, they get a severe COVID-19, were immunosuppressed. Next slide, please. This is old data. I think this is from the alpha and delta variant. If you see a hematological malignancy, so there are significant numbers, 3,377 patients. This includes adult and pediatric studies from all over the world, and the mortality is 34%. So someone adult patient having a hematological malignancy, chances of dying with the COVID-19 was 34%. And if you are above 60, the risk ratio or the relative risk is 1.82%. So if you are elderly and you have a hematological malignancy, there's a 47% versus a 25% died because of COVID-19. So there's a significant mortality because of COVID in our patients. Next slide, please. This is the data, the multi-center international experience in CLL. Next slide, please. There was a symptomatic COVID-19. There was 198 patients. 45% were receiving the active CLL therapy, and among them, the most common was BTK inhibitors. 90% require out of this 198, the 90% had required a hospitalization, and the overall case fatality rate was 33%, and there was a prolonged hospitalization in another 25%. It's not only the patients who were receiving the therapy, they was in the different phases of the diagnosed on observation. They all were included in this. In spite of that, they may not be on the therapy, regardless of the disease phase or the treatment status. So the disease itself, rather than any particular treatment or chemotherapy, would have led to the increased mortality. Next slide, please. This is from European Research Initiative on CLL. Next slide, please. Probably a similar data, 190 patients from across the Europe. 79% of the patient had a severe COVID-19. They required oxygen and intensive care admissions. And if you see a pattern, roughly 1/3 of the people, we lose them. And there are various parameters, the age, whether you are on BT. Initially, there was some distinct BTK inhibitors are protective, but I don't think there has been confirmed. Age and comorbidity did not impact on the mortality. So the role of the per se the disease and the underlying immunodeficiency led to the increased mortality. Next slide, please. This is data in lymphoma multi-center study published in Hemisphere. Next slide, please. 177 patients. There also the overall mortality rate was 34.5%. And if you had an active disease, that has significantly increased the risk of death. But if you are on active treatment and your disease is under control, probably that did not modify the mortality risk. So initiating, if your disease is under control, even though you are on chemotherapy, probably that did not change the mortality. So definitely not only the CLL, the lymphoma patients also compared to the general population had increased mortality. They advised even interruptions or delay did not reduce the mortality. So probably the active treatment should not be stopped, and but that's not going to change your mortality if you are delaying the treatment or holding the chemotherapy. Next slide, please. This is a data recently published from our group, the SCC, and there are 10 centers involved. Next slide, please. This is a hematological cancer registry of India COVID-19, and they had all the patients with the hematological malignancy, and they had a confirmed COVID-19 patients from 10 centers. 565 patients, follow-up of 90 days, 116 patients, 20.5% died. Among them, 64.7% had a severe COVID. There was and the majority would have survived, expired within 14 days of diagnosis. There was various factors have been shown, but I think this also shows in our country also The people who may not have been captured in data, so probably the proportion may be slightly higher, but whatever data could be captured, at least the mortality was 20.5%. We can say now this variant is mild and there's not much mortality. Why we want to discuss about this antibody and why we want to discuss a COVID-19? But I can tell you, still I'll be worried if I'm taking a patient for the transplant. My patient should not get COVID-19 in between the process of transplant. I don't know what effect this even a mild variant will have on my patient. Recently, we have delayed one patient's starting AML chemotherapy for 7 days just because you need to have a quarantined, or you will be worried if you start a chemotherapy when there is active infection going on, would impact it. So though it looks milder for the general population, may not be mild for our patients, and definitely it changes your treatment decisions, and you will be worried because of this infection going on. Next is the efficacy of vaccine. We have all the data commonly published in the news from the general population, but definitely the vaccine efficacy is reduced in the people with our malignancies. Next slide, please. This data is from UK, significant numbers. They had 5 million people, and they have seen there was a multiple comorbidities, and especially if you are immunocompromised, the efficacy after the one dose and after the second dose was not to the mark. If you see with the other comorbidities, there's a effectiveness is documented. But if you see with the immunocompromised, whether it's a first dose and whether completing the vaccination did not show significant response into the immunocompromised patients. Next slide, please. This is a data on the antibody response. Even if you have vaccinated, if you have a hematological malignancies, 46% of this data, this is responses were measured and patients with hematological malignancy, 67 patients. After the 2 doses of mRNA, 46 of the patients were considered non-responders, a significant number. So roughly a half of the patient did not mount antibody response after the vaccination. Among them, the most compromised were a CLL, followed by lymphoma and myeloma. Next slide, please. This is whether you produce it or persistence of COVID-19 antibodies. There was 45 patients with the various lymphoproliferative and myelomas and myelodysplastic syndromes. The seroconversion rates were lower in comparison to the controls, and lymphoma were lower than the other hematological malignancy. All the 9 patients who had received a rituximab within 6 months before the COVID-19 failed to produce these things. So someone has been exposed to rituximab, that's a B cell antibody, your antibody production is significantly compromised. And we are using the rituximab left and right for the various indications, especially in lymphoma. So someone who is going through the treatment or he's been treated in the last 6 months, the chances of mounting the antibody response is very low. Next slide, please. This is the impact of the humoral immune response. This is an international study published in hematological malignancies. Next slide, please. Recently published. 551 patients with the hematological malignancies, included all the lymphomas, leukemias, and myelomas. They did this IgG antititers, and comparing the healthy controls, the patients with the hematological malignancy had a attenuated antibody response, whether at 1 month or the 3 months. And there was a very low neutralizing capacity, which was counted as the 1/3 or the one half of that 3 months, despite the positive seroconversion rates. Various the BTK inhibitors, venetoclax, PI3 kinases, or all the monoclonal antibodies had substantially reduced the responses. There may be a combination of the drugs. Sometimes a single drug may not have that much bad impact. Next slide, please. Next slide. There's a similar kind of a data. Next slide. This is in all the cancers. This is a meta-analysis, 35 studies. So the non-cancer control versus the oncology patient has less likely to attain a seroconversion, and the hematological malignancy had the significantly lower seroconversion in comparison to the solid tumor. So the general population versus the cancers, and cancers among the hematological malignancies versus the solid tumor, there was a significant chances of mounting a response was very low, and they had a higher likelihood of having a documented seroconversion. This translated, in spite of immunization, higher rates of recurrent or COVID-19 infections. Next slide, please. This data, if you see the antibody responses, the circled area, which showed you the patients with the cancers, and particularly the hematological malignancies, after the 2 doses had a reduced immuno response. Next slide, please. After the transplant, this is data on the after the transplant, 93 adult patients, including the 29 autologous and 64 allogenic, they've shown a reasonable seroconversion. But if you are early into the transplant, and if you have a low B cell count, and if you have been treated for GVHD, and you've been on the highly immunocompromised, less likely to mount a response. So, and if you are on cyclosporin, so one of the factors is the cyclosporin will be a predictor, negative predictor or a seroconversion. Next slide, please. What about the third dose? If you give it a third dose, you say, okay, so if you're going to take a patient for transplant, or you're going to treat it, whether you want to give a third dose of vaccine, with say booster dose, whether that will be enough. That the general population with the 2 doses and the 3 doses for the immunocompromised, whether is equivalent. Next slide, please. There's some data, very limited. I think the data will be building up, but the people who have received a third dose, individuals with the CLL and other B-cell lymphomas with the previous, if you're treated with the anti-CD20 antibody in the last 12 months, had a no significant response after the third dose. And similarly, if you've been on rituximab and vaccinated with the third dose, the responses, the antibody responses were 32 and 22%. So even a third dose is not very effective in our patients. Next slide, please. I think the goalpost is changing. So what variant will be there, and how the vaccination and then the third dose. But I think the situation keeps changing. So we had to be ready for what comes next, kind of. This is a similar data for the third dose. 172 patients had the antibody response was only 23.8. So we have a little bit of data saying that if you receive a third dose, still you are not protected against the COVID infection. Next slide, please. This shows you that similarly, if you've been on the treatment naive or on therapy, apart from the off therapy, your responses are poor. Next slide, please. Do we have something to say we can protect apart from the vaccination? So this is one new antibody which has been recently given an emergency approval from FDA, has been developed by AstraZeneca, has been named as a AJD7442. The other name is Emishield. I'll show you some slides. Next slide, please. This is a combination of 2 long-acting antibody. So one is called silgavimab and tixagevimab. So fully human monoclonal antibodies, different epitopes. It has extended half-life, potentially up to 12 months. The FDA has given approval up to 6 months, but we have in vitro data up to the 12 months to say it has adequate persistence. And it has a good safety profile, easily intramuscular administration, and you need a single dose. On single dose, 6 to 12 months protection. You can easily take the patient through the AML therapy or your transplant patient. If the way the things are going, even if it is a mild variant, if the cost is not a bar, if I had to take a patient through the chemotherapies, I would prefer to, provided it is safe, I would like to have some kind of this extra protection, especially when the vaccines are not showing adequate response. We will be excited to see what does it shows. Next slide, please. So they have done some modifications. There are some domain modification which is called a YTE modification. I don't know about this. That promotes their antibody recycling, and that has increased the half-life of the antibodies by 4 times. Usually it's 20 days. It has been converted to 70 to 100 days. It has increased the localization to the mucosa, and so that's how it is more into the upper respiratory tract. So there's some modifications that be done which has prolonged the half-life, and at the same time it has it goes to the upper respiratory tract. And it has a different the reduced binding to this, so less likely to have immunopathology. So if it's not binding to these complement proteins and the receptor, Fc receptor, then there is a decreased chances of immunopathology. Thank you. Next slide, please. And this is an in vitro data. The protective level has been said is a 2.1. MEC of this thing is 2.1. So if you see at 12 months, your half-life of the peak serum concentration is quickly. So you have a quick response as soon as the antibodies goes in. You have a quick response, and it is a persistent. So this is in vitro serum levels of AZD7442 over 12 months, and this is with the single injection intramuscular. Next slide, please. Next slide. So what data we have it? It has been tried into various components of the infection. Prophylaxis, so pre-exposure prophylaxis. I don't know whether we had any. I'm not the COVID expert, but I don't know whether we had it anything before the exposure. So anyone who is not been exposed, you're worried about this thing, or whether you can protect them before the exposure. So pre-exposure prophylaxis, we have a data. Is a trial is called a PROVENT. Then is a post-exposure prophylaxis. Then we have a preemptive treatment, and then early treatment, the early phase of symptoms, and then there is a late disease treatment. So there are various trials. One is a PROVENT, other one is a Storm Chaser, and then is the Active 2, and then there is Active 3 Discovery. Next slide, please. I'm going to talk about the pre-exposure, so PROVENT trial. Next, please. And I'm more excited about this one rather than this thing. So there are 5,197 patients. They were 18 years old, more than 18 years old. They will be a candidate for benefit of passive immunization. Means they had an increased risk of inadequate response to the active immunization, and they had increased risk of infection. So by your characteristics, you may not be mounting an adequate response to the vaccination, and you have increased risk for the infection. So that kind of a population has been taken into this study. Next slide, please. Among them, the 7% had a cancer. Immunosuppressive medication was 3%, and the immunosuppressive diseases were in the less than 1%. Among all the other comorbidities, these were the this is a distribution of the other comorbidities. Next slide, please. Population was say roughly a half, more than above 60 and below 60. Different ethnicity was taken in. And if you see that 2/3 were into the antibody arm, the 1/3 was a placebo arm. The chances of severe COVID-19 was 0. Death from COVID-19 was 0 in the patients who had received this antibody, versus in placebo, the chances of severe COVID-19 was 3 and death was 2. The symptomatic cases, 25 out of 5,172 recipients. Next slide, please. So the people who are in the placebo arm, this is 1,700 around, the 1%, roughly 17 patients had a symptomatic COVID-19, versus a 0.2, the 8 patients out of 3,440 odd, it comes to the 0.2%. So the risk of infection itself comes down from 1% to 0.2%, and at the same time the risk of death and the severe infection goes down to 0. Next slide, please. And at the follow-up of 6 months, so the 6 months data, This was a 77% reduction at the initial, and if you see a 6 months follow-up, the whole 6 months, there is a 83% reduced risk of symptomatic COVID-19 with no severe disease or death. So basically, definitely you're preventing from the death and severe infections, and at the same time, you are reducing the risk of having a symptomatic COVID-19. Next slide, please. This is, I showed you the primary analysis and the 6 months analysis. There was a total of 5 cases of severe COVID-19 and the 2 deaths because of the COVID. They all were into the placebo arm. Next slide, please. So we have other data also, which is the storm chaser. There's a 73% relative reduction in the symptomatic COVID-19 and 92%. So there are various categories into the storm chaser, which is post prophylaxis and preemptive. And then you have early, the mild to moderate disease. If you give antibodies, there's a 50% reduction in the severe COVID-19 or the death when treated within 7 days, 67% if you are treated within 5 days, and it is 88% if you are treated within 3 days. So earlier you have received the antibodies, you have a far better protection. And then there is you have a long, if someone has a longer late exposure, late administration of the antibody, and the safety profile, there was no significant safety profile different from the placebo. The data is not there, but someone had a cardiac risk factors. Probably there may be some risk for the cardiac, but in general, this was a very safe prophylaxis, irrespective. So overall, it did well. There's some concern. Are there people who had a cardiac risk factor, but not major anything? So it is safe. It is effective. At least I would force for the pre-exposure. I'm not here to say how much is the cost. So if you put the cost aside, this appears to be good for my patients. Next slide, please. Whether it works in Omicron. So there is a data because the previous, all the antibodies which are available in India, there is a data to support these antibodies are not effective. So there are a few antibodies available. There's a data which is from there. The Casrinivimab and the combinations of, there are 2-3 combinations are available. This is called Evusheld. So the name has been given Evusheld, and this is a potency of neutralizing potency is being shown. In Omicron, they have shown potency reported in vitro therapeutic activity across these antibodies. So there is some in vitro data to suggest that it will protect against Omicron also. Next, not only the Omicron, the previous the Alpha, Delta, all the variants, it has effectivity. Next slide, please. So I think since we deal with a very unique population, which may have a milder variant for the general population, may be difficult to take the patient from through the transplant, then will be definitely worried about getting any any variant of COVID. So it provides an immediate protection. As soon as you administer, it has it starts working. It has been engineered to have a longer half-life, so potentially for 12 months of protection. It reduces the potential for the resistance or escape. So, I mean, this is I would say we need to prove it whether it will be effective for the subsequent variants or not. And for the Omicron also, there is an in vitro data, but we need to see it. I think the company must be building up some data on the Omicron also. And it's very convenient, single dose. That's it for 12 months. Next slide, please. This has been given emergency use authorization. Next slide, please. So for the emergency use, who are not currently infected with the SARS-CoV-2 and who have not had a non-recent exposure to an individual infected with the SARS-CoV-2 and who had a moderate to severe immune compromise due to the medical condition or receipt of immunosuppressive medication or treatment and may not mount adequate immune response to the COVID-19 vaccination. So this is an important thing. Someone, he's been moderate to severe immune compromise because of his medical condition or because of his drug. And if we have evidence that this kind of a condition, he may not be able to mount adequate immune response to the vaccination. So the priority is for, the authorization is for this. Next slide, please. Who comes into the moderate to severe? So this is that may benefit from this Evishield. The active treatment for solid tumors and hematological malignancies, recipients of solid organ transplants and on the immunosuppression, recipients of CAR-T and hematopoietic transplants, even within a 2-year of transplant, moderate or severe primary immunodeficiency, HIV, and then someone who is on the higher doses of the steroid. So the definition where there is the authorization is moderate to severe compromised condition. Next slide, please. There is some guidelines from NCCN. The patients with the hematological malignancies are more likely to have an adequate response to COVID-19 vaccination. They are at the highest risk for major COVID-19 complication. The committee agreed that a reasonable option is to prioritize these patients for this tixagevimab and silgagevimab. The committee remained agnostic on the use of the antibody levels to determine the priority, and such decisions should be determined at the local level until the additional data becomes available. But the important thing, if you have received a vaccination, it should be administered after the 2 weeks. So there should be a difference between the COVID, the vaccination, and the antibody for 2 weeks. Next slide. So where would I use it? Definitely before starting a transplant. I'm not comfortable starting a transplant in this phase. At the diagnosis of AML, we are delaying a treatment which
Audible? Yeah, hi.
yes.
Excellent talk, sir. You touched on this
Thank you.
point briefly during your talk with regards to you having a AML patient and who turned positive and you had to delay the induction by 7 days. So I think many of us are going through the same challenge. I myself had a high-risk AML with monosomy 7, is due for transplant last week. Unfortunately, his sibling donor turned positive. I waited for 7 days, tried to take him in yesterday, and then again he tested him, but he also is tested positive. So is there any data to say, is it safe to wait for 7 days and take it? Can we do it earlier or do we need to do later? Where does the 7 days come from, sir?
Now, you're talking about the COVID or AML treatment?
COVID and transplant. I'm talking about the post-COVID waiting period of 7 days to do either the AML treatment or the allowed BMT.
No, I mean, it depends on how much damage the organs have it. So your chances of having a severe infection probably goes down significantly after 7 days. But if you had some damage done into the 7 days, so you need to have a reassessment of your chest before you taking for the transplant or anything. So I mean, it depends on what damage has been done in the last 7 days. But if you have passed these 7 days and if you are well enough and your lungs are okay, probably the chances of having a delayed will be lesser, and you need to balance it between. You cannot delay it forever. Bruce, you have anything to add on?
No, I think you've covered that quite well. Yeah, I think it all comes down to clinical judgment. If you think your patient is still recovering, you probably need to give them that window of opportunity to recover adequately. But yeah, it's individual judgment.
Thank you, sir.
Yes, Sandeep.
Sandeep, you have to unmute yourself.
Yeah, Dr. Dinesh, we started our patient for transplant conditioning regimen and started GCSF also to the donor, and then donor became positive, COVID positive. So what is the way?
Once you started your chemotherapy for the transplant,
yeah, conditioning was almost finished, and then
so,
we repeated,
unless you have some other donor ready, or I think if the donor is well and you have already finished a significant proportion of GCSF, probably you will go ahead. But if the donor is sick and he is hypoxic,
I talked to Dr. Bipin Savani in US. They say we go ahead and that the viral will not be transmitted. We went ahead with the collection and patient is still doing well and patient is still not positive. So
good. But we always will be worried about.
Is also now recovered. Fortunately, most of these patients having a mild symptoms, and so donor is also well, and today day 11 patient is still has not become positive.
So we all have experience with this Omicron. The people are still in the treatment. They're not been very severe. But if I have something to protect them prior to that, there will be definitely different combinations coming in. So if I have something to protect them before starting, that will be welcomed.
Okay, we have just a couple of minutes left and we have got many hands up still and some question in the question box. So small questions, quick replies. Hemant.
Hi Dinesh, thank you. Very nice talk. Again, beyond my core competence. So my question to you is, the monoclonal antibody which we talked about, does it cover all the mutants? Does it cover the Omicron? Does it cover the Delta Omicron? Or it is pan COVID?
Can I ask Bruce to answer it, because he'll be more competent to answer it?
Yes, certainly. So it covers all the variants. It was designed initially for the earlier variants, but when Omicron came, we did some very quick studies, and there's a few independent labs have looked at that, and it has lost some effectiveness against Omicron compared to Delta, for example, but still highly effective. So no concerns. It should work very, very well.
So what about a new variant? If you have another mutation, will it work in that, or you don't know?
So the beauty of this is it's two independent monoclonals that bind to different regions of the receptor binding domain on the spike protein. So designed like that deliberately, so that if you get a mutation that disrupts one, the other antibody will still work. So it should be highly resistant to any kind of mutation. That's the design.
Thank you.
Thank you, Hemant. Dr. Reshma.
Good evening, sir. Dr. Dinesh, excellent talk. and lucid as usual. So my question is, if post this antibody infusion, we want to vaccinate the patient, like we wanted to cover the transplant, it is done, patient is 6 months post-transplant, since the half-life is 12 months. So how are we going to vaccinate the patient post-infusion of this antibody?
If you are doing a transplant, at least 3 months. But I think the recommendation, is there any specific recommendation when you give this and when to give a vaccination? 2 weeks?
So just standard general principles, there's a gap. So people talk about 2 weeks. We do have data from non-human primates where we looked at using the monoclonal cocktail prior to vaccination, and there was almost no impact, to be honest. Hypothetically, there's a risk that the monoclonal will blunt the vaccine response, but we saw no impact in non-human primates. We don't have that data in humans yet. It's coming as an extension from that proven trial. But at the moment, the data we have suggests that there's no risk in terms of treating with the monoclonal before you vaccinate, but just normal practices to try and separate treatments. There is a recommendation, I think, of a 2-week window.
Thank you. One last question we have. This is a question from Nepal. Dr. Prakash Nidhi Tiwari wants to know, he has got 2 parts of the question. 1, is it available in Nepal? And 2, what is the cost?
I don't think it is available. I don't think.
Not yet, I believe. So we've only just received emergency use authorization in the US. There's a couple of places in the Gulf. Singapore has received its first shipment already. So it's rolling out, but it's still coming to many, many countries. I won't speculate on the cost. That's a local decision based on the climate. So that's not my area.
Right.
As Dr. Hemant said, I'm also not the expert of this field. So
thank you. I invite Dr. Shweta Surve, who was actually supposed to speak even before Dr. Dinesh, but I apologize, Dr. Shweta. Once again, I made that error.
Oh, no worries, sir. Thank you so much. Thank you so much, Dr. Dinesh. I think it was a very elucidative and educational talk, and it gave us an information on a completely new disease area. Completely new area as well. And thank you so much, Dr. Agarwal, as usual, for this opportunity to be a part of MHG and Best of ASH for this particular session. Thank you to the organizers as well. And on behalf of AstraZeneca, thank you so much.
Thank you, Dinesh, Dr. Bruce, Shweta.
Thank you, sir.
Thank you.
We move on to the second lecture of this webinar today. We already have Dr. Andreas with us. Thank you so much, sir, for joining. He doesn't require any introduction. Everybody is interested in the field of chronic myeloid leukemia in this country. You've heard him in past, you read his work, he's an authority on the subject. As you know that he is from the University of Jena at Germany. And over to you, sir.
Yeah, hello, good afternoon, good evening to you. As mentioned, we had a meeting last year together, but today I want to focus on the data from ASH, on the new ideas which came at ASH, and I'm very grateful to have this big audience here in your country. So thank you very much. I share my screen, and you mentioned that I got 45 minutes for the update. Is this right?
Sir, you have 60 minutes for the speaking and 30 minutes for
Oh, that's a little different from what I prepared. I prepared 45 minutes, but I could be a little longer. That's no problem. Yeah, okay, very good. An update, what was new at ASH? The problem at ASH was, of course, that most of us were not present at the meeting, and it was more a virtual meeting than a meeting between friends and colleagues. But of course, everybody was able to listen to the presentations, what is new in CML. I would like to focus on the new drugs, on dose optimization studies, on a little bit on treatment of advanced disease, treatment-free remission, of course, and that what you just discussed in the previous meeting, COVID-19 in particular in CML patients. I showed this slide already at our last meeting. That's the evolution of the ELN recommendations over time. And the status, the current status of CML treatment on the right in the red box, 2020, we have 4 licensed tyrosine kinase inhibitors now in Europe available. I think you have in India other inhibitors as well in addition. A second-line treatment with ponatinib as a 5th drug, salvage treatment, of course, allogeneic stem cell transplantation, and our most important milestone now, MMR, is more and more changing to DMR, because with deep molecular response achievement and consolidation, we are able to discontinue treatment. Still in the minority of patients, but this should be larger, this cohort should be larger, and we work on that. And of course, the new drugs which are now available should guide us to this goal of discontinuation of treatment. Our concern are still the side effects, mainly based on off-target inhibition of alternative tyrosine kinases, for instance, the vascular effects, the pleural effusions, and others. And we try to avoid these, to circumvent these side effects with more specific BCR-ABL inhibitors. And that's, of course, and I start with the new drugs, that's, of course, asciminib. Asciminib is based on the inhibition of the myristoyl pocket, which is auto-inhibited in the normal ABL by binding of the N-terminal myristoylated end to the myristoyl pocket. It creates auto-inhibition towards inactive ABL. In case of BCR-ABL, this is not possible because the myristoyl end does not exist anymore, because BCR has substituted this myristoyl end, and we have 2 open pockets. One is the ATP binding site, and one is the myristoyl binding site. And the myristoyl binding can be imitated from the myristoyl tail with a small molecule, which is asciminib. That means we have now 2 options to inactivate BCR-ABL. One is the binding of the classical ATP competing drugs, and the other is the binding of asciminib. Asciminib is BCR-ABL specific, seen here in the preclinical work. The red dots represent BCR-ABL positive cell lines, the blue dots BCR-ABL negative cell lines. That means from all these drugs here listed, asciminib is the most specific BCR-ABL inhibitor. So now the update of the ASSEMBLE trial. This was presented by Michael Mauro from New York, the so-called 28-week visit, or the 28-week update. The 48, sorry. The 48 weeks are in the pharma language 1 year, crazy enough. But it's 1 year, 48 weeks, because all these studies are labeled in 48-week categories, and that's always 1 year. This study was a randomized trial, or is a randomized trial for third-line or later-line chronic phase CML patients. And the randomization is 2-to-1 for asciminib against bosutinib. Asciminib 40 milligram twice daily, bosutinib the label, which is still 500 milligrams. We all know that 500 milligram bosutinib lead to diarrhea and liver tox, but since this is in the label for a later line treatment, this was used here in this study. The randomization was stratified by a pre-existing response or non-response, stratified by major cytogenetic response at diagnosis. And the major endpoint was week 24 MMR rate, and we now report 48-week data. The treatment is ongoing for asciminib in 56% of patients, for bosutinib 22%. That means most bosutinib patients left the study based on side effects or lack of efficacy. Some patients left the asciminib arm as well because lack of efficacy, only a few because of adverse events. And this is the most important data. The MMR rate is different between asciminib and bosutinib, an advantage for asciminib, a significant advantage. But for my feeling, more important in the third-line situation is the BCR-ABL level of 1% or complete cytogenetic response, because our goal, according to the ELN recommendation in late-line treatment, is the achievement of a 1% level, not the MMR. MMR is nice to have, but for the safety of the patient, the 1% is sufficient, as we know from long-term data, and therefore this data is important as well. And here we see an advantage: 42% of patients with asciminib and only 19% of bosutinib patients achieved this 1% level at 48 weeks. What about the different lines of treatment? There is an advantage of asciminib for all lines of therapy. Considering the MMR rate, you'll see that the advantage is most prominent for first, fourth line and fifth line treatment, is less striking in the third line treatment. That means the bosutinib was quite active in third line as well. This is the cumulative response for the MMR rate for asciminib versus bosutinib. Starting at 12 weeks, we see an ongoing advantage of asciminib over bosutinib, and this is the case for the 1% level as well. Here we start the difference at 8 weeks. We performed monthly PCRs, that means at 4 weeks, at 8 weeks, at 12 weeks in the study, and we see the first advantage at 8 weeks for the 1% BCR-ABL level. Late line therapy is not the ideal background for treatment discontinuation. Therefore, the deep molecular response are of less interest, but we checked it, and we see even in this very late line therapy, 10% of asciminib treated patients in MR4 and 3.9% of the bosutinib patients, and 7.6 versus 1.3% of MR4.5 in this late line. This does not mean that we want to discontinue therapy here, but it's interesting how a specific BCR-ABL inhibitor is able to downgrade the clone, the BCR-ABL positive clone. This is of course needed. The BCR-ABL as a driving force is needed here, which is obviously still the case. Even in the third line situation, we expect a clonal evolution, we expect additional molecular aberrations, but at least in this minority of patients of 10% and 7.6, the driving force is BCR-ABL only. Side effects are depicted here. As expected, we see with bosutinib gastrointestinal side effects and liver toxicity, in some patients with asciminib as well, but the difference is significant. But we see more cytopenias with asciminib compared to bosutinib. My interpretation is that these cytopenias are based on the efficacy. That means it's a suppression of the leukemic clone by asciminib and a slow recovery of the normal hematopoiesis. And in this period, in the first months of therapy, we see a transient cytopenia until the normal hematopoiesis has recovered. And this is the case for the more active drug like asciminib over bosutinib, and therefore we see more cytopenias. I do not expect an impact on the normal hematopoiesis. There is no sign for suppression of normal hematopoiesis. And that this interpretation might be correct is seen here with the timing of the different kinase inhibitors. We see that the cytopenias, thrombocytopenia and neutropenia occur mainly in the first 6 months of therapy and not later. And the persistence of these side effects is seen on the right side, and you see that it goes down. The all grade cytopenias are reduced over time until 6.8% for the thrombocytopenia after 18 months of therapy. Of course, these are low-grade thrombocytopenias. Otherwise, the treatment would have been discontinued. So in summary, I think the most important message here is that BCR-ABL is still the driving force in the majority of patients in third line and later line situation. And the BCR-ABL specific inhibitor is able to suppress the leukemic clone. I think the major advantage of asciminib is the specificity for BCR-ABL, reducing the off-target inhibition and therefore the off-target side effects of the drug. The comparator bosutinib is, of course, not the ideal comparator because we don't treat with bosutinib 500 milligrams from start of therapy. We now escalate the dose, but this is not in the label. Therefore, the study was done that way. Of course, the real-life comparator for late-line therapy will be ponatinib. And of course, there's a lot of comparison ongoing. I think these are two very individual and specific options for the treatment. The broad spectrum ponatinib and the very specific asciminib are both able to treat third-line CML patients, but most probably not mutually exclusive. That means we have two chances for these patients, and therefore the early endpoint for asciminib, 24-week MMR, might be correct because we need an early answer how these patients will respond to one of the drugs, ponatinib or asciminib. So that's asciminib. What about other drugs? There's a drug from China. This is olverembatinib, a difficult name, or HQP 1351 in the literature. And the colleagues, Professor Qiang has presented phase 1 data from a phase 1 trial using this drug in resistant CML patients. The interesting point is that this drug is inhibiting the 315 clone as well, and it's predicted that the vascular side effects will be lower as with ponatinib, but of course that's not a comparative study. That's a dose escalating phase 1 study. You see here the summary of the efficacy data, starting from major cytogenetic response for most patients to even deep molecular response in cumulative terms in more than 20% of patients in MR 4.5. That's marvelous for a phase 1 trial and for a third line situation in chronic phase, but also accelerated phase patient responded to the treatment. We see new side effects which have not been observed previously. Most frequent is skin pigmentation. We have observed early in the development of the tyrosine kinase inhibitors skin depigmentation with you may remember the results with imatinib when we saw vitiligo and similar skin toxicities based on the inhibition of the melanocytes. But here we see a skin pigmentation and some other side effects, nothing important, according to the data presented from China. A third new drug is vodobatinib. And here, in contrast to the Chinese study, this is an international study led by Jorge Cortes from MD Anderson, previously MD Anderson. He is now in a new cancer center in Augusta. And he presented this data. Vodobatinib is also more specific. This is shown on the right side. The inhibition with vodobatinib is more specific towards ABL and BCR-ABL, of course. It does not inhibit the 315 mutation, but it's predicted, since vodobatinib does not inhibit the VEGF receptor, in contrast to ponatinib, that it will not create vascular side effects. Efficacy is quite good in the phase 1 trial. There's a dose escalation and a dose expanding cohort on the left and on the right side. And you see here the response rates, major cytogenetic response in 2/3 of the patient as best response. And that's, of course, another new drug. I'm not sure how this will go into our strategies. Asciminib is certainly the 6th available inhibitor now, which is registered, because asciminib was registered by the FDA for third and later line therapies and for the 315 mutation. For these other 2 drugs, we need to wait what the development and in which countries these drugs will be developed. But it's well tolerated. It deepens the response. That means nothing against this drug, but whether it shows a new profile, a new inhibitory profile, and a new side effect profile needs to be demonstrated in further trials. Now, I would like to discuss dose optimization. We know that all the tyrosine kinase inhibitors started their development with the wrong dose. Imatinib was started with 400 milligrams. We know that a higher dose, 600 milligrams, for instance, according to the CML4 study in Germany, works better, with a little bit more side effect, but better efficacy. We know that the first trial with nilotinib started with 800 per day, was too high, created too many vascular side effects. 600 is now the standard dose. Bosutinib, 500, far too high. We are now with 300 and 400 milligrams with better tolerability. And here it comes to ponatinib. And with ponatinib, the PACE trial used 45 milligram once daily. And this led to the discontinuation of the trial because the FDA realized more than 20% cardiovascular side effects with this option. Patients were not selected based on their pre-existing cardiovascular side effect profile. That means this was too dangerous. And therefore, the FDA requested new data on new dose profiles. And this was the background for the OPTIC trial, optimizing ponatinib treatment in chronic phase CML. 3 cohorts were randomized, not as a comparative study, but for the individual cohorts, for the efficacy and the tolerability in these 3 cohorts. 45 milligrams starting dose, dose reduction to 15 milligrams in case of response. That means 1% BCR-ABL or lower. Same for 30 milligrams, reduction to 15 in case of 1% BCR-ABL or lower. And the third cohort starting with 15 milligrams per day. The endpoint is a 1% BCR-ABL level. The cohorts are balanced based on the cardiovascular risk profile. Here, hypertension, diabetes, and hyperlipidemia. And they're also balanced according to mutations or no mutations and according to the 315 mutation, which is, of course, sensitive to ponatinib. The cohorts are quite balanced according to the number of prior tyrosine kinase inhibitors, and resistance was by definition, by protocol, the requirement for the participation in the study. And this is the most important data. The statistics were calculated in a way that the expected efficacy should be that the lower bar of the confidence interval should be higher than 20%. And you see here the data, the response data, 1% level at 12 months for the 3 cohorts. And you see that only the 45 milligram cohort achieved this goal. That means the confidence intervals are between 31 and 57%, and this is above the 20% level, which was expected. That's not the case for the 30 milligram. That means, according to the strict protocol of the study, the starting dose of 30 milligram is not recommended for the general use in the coronary phase CML patients. It's, however, recommended if the patient had severe cardiovascular pre-existing disease, if ponatinib is needed in such a patient. Of course, should be avoided, but if it's needed, we can start with 30 milligrams. But in general, we should start with 45 milligram once daily and should reduce the dose to the 15 milligram when the 1% level is reduced. This is demonstrated here with the actual dose intensity. The dose intensity by 6 months was in the high dose cohort 35 milligrams. That means some patients have already reduced the dose. In the middle cohort, still 30 milligrams. That means all patients were still on the starting dose. And in the 50 milligram cohort, it was, of course, 15 milligrams. This is different by 12 months. By 12 months, all the patients who were still on treatment with 45 in the 45 cohort were at 15 milligrams. That means they had all reduced the dose to 50 milligram. That means the protocol requirements are feasible. They have all worked in these cohorts and were applied to these dose levels. And the response level is stable after reduction of to 15 milligrams in about 75% of the patient. You see it here for the 30 to 15 milligrams, stability for 78% of the patients, and for the 45 to 50 milligrams, stability in 73% of the patients, again demonstrating the feasibility of the dose reduction. And the subgroup analysis by 3 years by baseline BCR-ABL levels, high-level patients, of course, benefit very much from the higher dose, 45 or 30 milligrams, but the difference is even more striking for the lower dose of for the lower BCR-ABL levels. That means for the patients who had lower than 10% at baseline. But it applies to both cohorts, and it applies also to all the mutations, to patients with mutations or to patients without mutations. And this is shown here. In the dark blue bars, you see patients with 315 mutation, a very, very good benefit of the high dose 45 milligrams. The benefit is much lower for this cohort with the lower dose. That means you need the high dose of ponatinib to suppress the 315 positive clone. Progression-free survival and overall survival is for late-line therapy quite good and very similar with the different dose cohorts. So now we compare with this slide, we compare safety differences with efficacy differences. And here you see the, here is an error in the middle bar, sorry for that. It's the difference in the side effect profile between the patients in the different cohorts, and you see 5% for 30 milligrams, 9% for the high dose arteriovascular side effects, and 3.2% for the low dose. That means the difference between low dose and high dose is 6.4%. But the difference for efficacy between the low dose and the high dose is 26.3%. That means it's very much advantageous to start with the high dose and to reduce the dose as soon as possible to avoid cardiovascular side effects. So, and this is now, and this was presented by Elias Jabbour at ASH. This is now the comparison of PACE with OPTIC. The PACE study was the study which was the first phase 2 study with 45 milligrams of ponatinib, which was closed by the FDA, started very early, almost 9 years ago. The OPTIC study started 5 years later. Therefore, the difference between the two studies is first the timing, and second, the dose levels with OPTIC, and third, that we knew when we started the OPTIC that cardiovascular side effects are a problem, and selected the patients accordingly. Patients were not selected in the PACE study. You see, most patients were resistant, and the profile of BCR-ABL is very similar, and also the number of prior TKIs. That means between 53 and 60% of patients had 3 or more previous TKIs before ponatinib was started. And this on the left side is the actual dose intensity which was used, with PACE, according to the protocol, much higher than with OPTIC, because in OPTIC we wanted to reduce the ponatinib dose in case of response. And this is the final data. This is the achievement of the endpoint BCR-ABL less than 1%. And you see that's quite similar. That means even a little bit better with OPTIC, because the severe side effects were lower, and this improved the overall efficacy of the drug. That proves that this option to start with 45 and to reduce to 15 is advantageous when we compare PACE with OPTIC. And these are the side effects. In the red bars, the old study with pre-existing unknowns according to the cardiovascular side effects. And in OPTIC, we knew what we did, and therefore we selected the patients accordingly. So this was OPTIC final data, demonstrating that we should start with 45 milligrams and to reduce the dose. Now, advanced disease. Advanced disease, blast crisis, is still a black box for most of our colleagues, because we don't know at which situation we need high-dose chemotherapy, in which situation we need tyrosine kinase inhibitors, and in which situation, if possible, always, we need allogeneic stem cell transplantation. But for the preparation of allogeneic stem cell transplantation, we need the elimination of the blasts. In my clinic, I start with the tyrosine kinase inhibitor, most importantly in the patients who start with blast crisis at diagnosis. We don't need a high-dose chemotherapy in all patients. Therefore, I was a little surprised to see this phase 1/2 trial here from England, or from Scotland, actually, that means from the UK, showing a fixed dose of ponatinib, 30 milligrams, combined with FLAG-IDA chemotherapy for all patients in blast crisis. There are 10 patients who had the blast crisis de novo, that means at diagnosis, and 7 patients who progressed after previous treatment. Even in the de novo situation, some patients were started treatment with other TKIs, but were switched then to ponatinib. 3 patients had BCR-ABL mutations, the other patients not. That means it's a mixed bag between myeloid, lymphoid, different lines of therapy, but all these patients were treated with FLAG-IDA plus 30 milligrams of ponatinib. And the survival results are, I think, intermediate. I would say with a 50% survival after 1 year, including allogeneic stem cell transplantation, is not very bad, but it's not very good as well. And my conclusion is we should treat these patients individually with the individual dose of chemotherapy. That's what is needed to eliminate the blasts before we go to allogeneic stem cell transplantation. That's my personal conclusion out of this study, but we should discuss this later. Now I want to discuss treatment-free remission. The first study investigating treatment-free remission was the STIM study from France, published 2010 and again 2012. Definitions were a deep molecular response at start of discontinuation, and any relapse PCR positivity was a decision to restart treatment. This was different in EuroSki. In EuroSki, the relapse was defined as loss of MMR. In the company studies, DAS3 and NS Freedom, it was similar, loss of MMR. And NS Stop was a study which improved the response rate on imatinib if there was a lack of deep molecular response by nilotinib, and then nilotinib was stopped. It's not a second-line treatment because all patients had a good response, but not a deep molecular response. Therefore, it was an optimization of treatment. And with this optimization, the discontinuation was, of course, possible. The surprising fact, when we look at these 5 curves here, is that most of these curves, if not all, end up with 50%. That means with different inhibitors, with different definitions, we have a stability of the response and an ongoing treatment-free remission in 50% of the patients. And the question was, and I discussed this at ASH in the educational talk, how can we improve this number? We can improve, of course, the number of patients who are eligible for discontinuation. And this is, of course, achieved by the more stringent induction treatment. That means the induction of the deep molecular response, for instance, with second-generation inhibitors versus imatinib, is more frequent. That means we can induce deep molecular response more frequently with dasatinib and nilotinib compared to imatinib, for instance. And then the consolidation of deep molecular response is a matter of time. How long should we consolidate the deep molecular response with the inhibitor? That's unknown. Most studies used 1 year, some studies now 2 years. We know that with a longer consolidation period, we are able to improve the response rate over time. This is the update of the EuroSki study, which was presented by François Mahon at ASH. The European trial with more than 800 patients. Now more than 700 were eligible for the trial. And you see that we see late relapses. That means the curve goes slightly down, gradually down over the years. That means conclusion is we still need PCRs on follow-up because we see in some patients a loss of major molecular response even after 3 years of therapy. But most patients who lost the response lost it early. And we know from previous data, ASH 2017, that the longer consolidation phase in deep molecular response will lead to an improvement of the stability. And Markus Firman calculated with a statistical method that the increase of the probability to stay in treatment-free remission is 3% per additional year of consolidation in deep molecular response. This is a marker, this is a benchmark for future trials. We come back to this benchmark later. The conclusion out of the EuroSki study is that the early loss of MMR is predictable by the treatment duration and the duration of DMR. That means you treat the patients the longer you treat the patients, the longer the DMR was lasting, the better is the early relapse rate. But the late major molecular response losses, the late relapses, are based on the TKI treatment duration only, not the duration of the DMR. This was not predictable in the multivariate analysis. So now I come to the NS-PASS study. The NS-PASS study was presented at ASH by Delphine Rea, and Delphine showed this very complicated trial. I already mentioned that patients were included who were on imatinib, but not in deep molecular response. They had a complete cytogenetic response or a 1% BCR-ABL level, but not an MR4. They were switched to nilotinib and as an induction phase, and stabilized with nilotinib in case of achievement of MR4. And patients who had a 1-year stable MR4 were randomized to continue nilotinib for another year or to discontinue therapy immediately. That means we compare here the 1-year nilotinib consolidation in deep molecular response with the 2-year nilotinib consolidation in deep molecular response. What do you expect from the improvement of stability in this situation? We learned from IRIS 3% per year. We achieved here 5% improvement, but this is not significant. There's no significant difference here in the statistical test because the power of the analysis predicted a higher difference to demonstrate the advantage of the longer nilotinib treatment. And these are the curves, the relapse curves. Of course, these are lower than the curves which I showed you in the beginning, because here we have a negative selection of patients towards patients who had in response to imatinib, which was not optimal. The difference here is 5%. I would say that's a very positive result because we saw this improvement, which was already predicted in the EuroSki trial, but it was not statistically significant. Therefore, for Novartis, it was a negative trial. But if any Novartis people here listen to my presentation, I think this trial is very, very positive and demonstrates that the longer consolidation period with a tyrosine kinase inhibitor is advantageous when we have time, when the patient has no side effects, when there is no wish to get pregnant or other urgent parameters, then of course we should consolidate a little longer. Patients who were retreated achieved a very rapid major molecular response in the 2 arms, also some deep molecular responses. That means it was no danger to start treatment in this study. So that's my prediction, how we can improve the TFR situation. We start at diagnosis. We treat as optimal as possible with tyrosine kinase inhibitors. We can achieve deeper molecular responses in more patients with second-generation inhibitors compared to imatinib. We need to discuss the maintenance period, 1 year, 2 year. That's what I discussed in the previous slide. And then we have the option to introduce experimental therapies. We know that all of these patients after TKI maintenance have persisting BCR-ABL positive stem cells. These stem cells do not express a high level of BCR-ABL transcripts because they are dormant stem cells, but they have activation of other pathways. We know from preclinical data from MD Anderson that BCL2 is highly expressed in such patients. We know the activation of the JAK-STAT pathway. We know the activation of the BTK pathway. And we know, of course, the sensitivity towards interferon alpha. That means all these drugs, the inhibitors, but also immune therapy, are experimental options to eliminate or to create dormancy in the persisting stem cells. That means these are the type of trials which we may see in the next years to introduce these drugs into the maintenance period of prior to discontinuation. This is, of course, not a combination treatment with tyrosine kinase inhibitors, but an additional treatment after discontinuation of the inhibitor. Here's the first part, the eligibility for TFR. This was investigated by within the NSND's trial. The eligibility over time is increasing with nilotinib towards close to 50%, with imatinib 35% eligibility. We know from a Japanese trial that the deeper molecular response, that means achievement of PCR negativity in this trial compared to MR 4.5, is advantageous. That's, I think, very difficult for the interpretation because we don't know the individual sensitivity of each PCR test. Is the upper curve with the PCR negativity, do these patients have the similar sensitivity of the assay compared to the positive patients, but who are in MR 4.5? But the difference is striking. That means with the with a better inhibition of BCR-ABL, we are able to create better data after discontinuation, at least in this Japanese trial here published in 2018. And new data from Adelaide demonstrate that the halving time of BCR-ABL at the start, the first slope of treatment between time point 0 and time point 3 months has an impact on the outcome after discontinuation. That means when we have a patient who has a very rapid response in the early phase of therapy, we can say that the predictability of stabilization of PCR is much higher, of TFR is much higher for this patient compared to the patient with the lower slope. And finally, we have, of course, an impact of the immune surveillance of these patients. T cells, NK cells, dendritic cells are active with the leukemic clone and can be activated by checkpoint inhibitors. But that's, of course, a very dangerous study because it may induce autoimmunity to the CML patients. But what is possible and what is ongoing is the introduction of interferon into this situation. And we have experience with interferon. We did here a small study with a combination of nilotinib and Pegasus, and the discontinued nilotinib first, or imatinib. It was imatinib and Pegasus. We discontinued imatinib first and achieved with Pegasus only a good stability of response. And then we discontinued Pegasus again as well and achieved a very, very good TFR rate. Only one patient has relapsed. All the others remain stable after the introduction of the immune activation by pegylated interferon. And that's now, this was the background published in 2015 for our ongoing Tiger trial. The Tiger trial is now closed and will be reported in the next year. We introduced as a maintenance therapy PEG interferon. This was PEG intron that time. After the combination of nilotinib as PEG interferon and stopped all treatment in deep molecular response. And the question is now whether the TFR rate, it's more stable with 1 year of PEG interferon monotherapy compared to the traditional nilotinib monotherapy. That's unknown, but will be answered next year. And another trial which is ongoing in Germany is the ROPEC interferon trial. ROPEC is a new pegylated interferon now registered for polycythemia vera, which can be used as a maintenance therapy as well. We do it in a comparative trial, in a phase 3 trial, and that's still ongoing. Results will be demonstrated next year as well. However, this hypothesis with the persisting stem cells, which I mentioned, is only one side. The other side is that colleagues in Adelaide investigated the lineage of the persisting cells, and they have seen that most of these persisting cells were lymphocytes and not myeloid cells. And these lymphocytes cannot, of course, create a relapse, a myeloid relapse of these patients. Therefore, the books are still open. We have to investigate this fact as well in comparison with what I mentioned. We need a genomic PCR to follow up these patients. That means what we do now is we sequence the BCR-ABL breakpoint on the genomic level in all patients and do in follow-up not only the RT-PCRs from peripheral blood, but also genomic PCRs, individualized PCRs, like in the lymphoma situation, very individualized PCRs to demonstrate the persisting stem cells. That's the PCR strategy. Here, a PCR-specific, a patient-specific design of the PCR and the sequencing results from several patients on the left side. So I now want to convince you with preclinical data that the combination or the maintenance treatment targeting alternative pathways is advantageous. Here you see venetoclax, the BCL2 inhibitor, combined with nilotinib, shows synergism with nilotinib in cell lines. And you see our strategy, which we plan to combine, to use venetoclax as a maintenance therapy after TKI discontinuation. This will start within this year as a pilot trial, stage 1, with 10 patients only. We expect a reduction of the genomic PCR clone in the persisting stem cells. If this is positive, we will start a randomized trial comparing the maintenance without any maintenance. We have a STAT3 pathway activation in CML, and this is, of course, targeted by a JAK inhibitor. We did a combination trial with JAK inhibitors and TKIs. This failed because of the side effects. Therefore, I'm looking forward to this combination trial of ruxolitinib and asciminib, which just started in the United States in a consortium in the United States. This could have an impact. A BCR-ABL specific inhibitor combined with a JAK inhibitor, which targets the persisting stem cells, which have a JAK pathway activation. And as a final, in the final minutes, I would like to discuss a registry which has been presented, an international registry led by the International CML Foundation. This was presented on behalf of the International CML Foundation here. 606 CML patients with a COVID infection were included. From them, 92% recovered, 8% died from COVID. This was most frequently in the first wave of COVID, a few patients in the second wave as well. The learning was here that CML does not impact the infection with COVID, and it does not impact, in most cases, the disease, the COVID disease in general. You see here the demographics of the patients, all patients, recovered patients, and patients who died. Median age was above 50 years. There were only a few patients who had smoked, which is, of course, a risk factor for COVID. But significant comorbidities were in about half of the patients present. These are the lines of CML therapy. Most patients were in first-line treatment, but some patients had 5 lines of tyrosine kinase inhibitors at the start of the COVID infection. Here, the severity of the COVID infection, critical on the right side. In some patients is a minority. Most patients had a moderate or mild COVID infection. So now it's an international study, therefore it's important to look at the regions. And the most important parameter for deaths was the origin. That means in the countries with the less developed health system, like in Africa, more patients died from the disease. That means it was not the CML itself. That's an important message. It was the management and the ability to manage the COVID infection in general. Here are the different kinases. Again, most patients were on imatinib. But the conclusion out of these studies is there's no specific pattern for the different kinase inhibitors for the risk to get infected and for the risk of the follow-up. The statistics showed that the origin of the patient and here the low-income countries compared to the middle and high-income countries and the comorbidities are significant and the CML status at the start of infection. That means many more accelerated patients and blast crisis patients died from COVID compared to the chronic phase patients. More patients without MMR died compared to MMR. And the multivariate analysis showed that the stage of the disease, the country of origin, and the comorbidities are the most important parameters for outcome after COVID infection. All in all, that's good news for CML. That means the CML patients should get vaccinated, as all other people, of course. And the response to vaccination is in chronic phase quite good. In contrast to chronic myeloproliferative disorders treated with a JAK inhibitor, and in contrast to patients with B-cell disease, of course. This is the result of the study. I think it was a marvelous study because it combined the experience of more than 50 countries, which was a very good achievement of the International CML CML Foundation. And I thank for the participation, also for participation of sites from your country. This is a summary of my impression from ASH. Not many news, but improvements, significant improvements for our patients, dose optimization, new drugs available. That means I see, again, as we say in CML, we see always light on the tunnel, on the horizon, but the tunnel is very big in the CML situation. We have some work to do for the future to improve tolerability of the drug and to faster achieve the response rates to be able to discontinue therapy earlier in our patients. Thank you very much.
Thank you, sir. Fantastic talk. You covered everything. We'll take some questions from the faculty here and the audience. We'll start one from the audience. Dr. Rajat Pincha wants to know which group of patients with cardiovascular risk factors were excluded in the OPTIC study.
I have not the protocol in front of me, but of course, patients with previous myocardial infarction. I think it was within 1 year myocardial infarction. But I'm not very sure here. Yeah.
Thanks. Dr. Prem Raj Shrestha wants to know, is it essential to monitor karyotyping by doing bone marrow, or that can be stopped totally?
I did not go into this because there was no new data at ASH. I would say a diagnosis, definitely yes, because we have risk factors, the major root and the high risk cytogenetic aberrations are a guide towards allogeneic stem cell transplantation. For instance, -7 or ISO 17 or second Philadelphia chromosome. For the follow-up, it's less important. But for the diagnosis, I would do it on follow-up if you see persistent cytopenias to exclude myelodysplastic syndrome in the BCR-ABL negative hematopoiesis.
Another question is regarding management of CML during pregnancy. No TKIs during pregnancy or any change in that recommendation?
First first 6 months, no TKI. I know that some colleagues have different approaches, like in Russia, the Russian colleagues are more open for the TKIs, but we are very, very, you know that we had this scandal with thalidomide in Germany 50 years ago. Therefore, we are very, very cautious here. We don't treat with TKIs in the pregnancy, if possible. I would ideally, of course, the patient should have achieved a deep molecular response, and we discontinue all therapies. If this was not achieved, I would bridge with interferon.
Right. So another question is, for TFR, should we decrease the dose of the TKI before stopping it?
I know that the Destiny study suggested this. I'm not convinced. I think in the Destiny study, this was more a stepwise selection. After reduction of the dose, some patients relapsed, and these patients were, of course, not discontinued. Therefore, more patients in the discontinuation phase had a stability because this was a positive selection. I think we need the most active drug prior to stopping to suppress the persisting stem cells. Therefore, I don't reduce the dose before I stop.
Hemant, your question.
Hello, Andreas. Good to see
Hello.
you even though virtually, and thank you for a lovely talk. My question to you is for the patient who has the T315I mutation, what would you choose today? Would you choose asciminib as first line, or would you choose ponatinib as first line?
Unknown. There's no comparative study. We know that patients after ponatinib had a response to asciminib, some patients, but we don't know how the response of ponatinib after asciminib is. This was not investigated so far. I would check the additional molecular aberrations. Is it 315 only? Then I would expect a response by both drugs. If they have additional epigenetic mutations like AXXL1 or so, I would use the broader drug, which is ponatinib over asciminib. But this is still open. We don't have prospective data for that. For the time being, we have no registration for asciminib in most countries. Even in Europe, we don't have asciminib available. We use ponatinib currently still.
And in the first line CML setting, you think a combination of asciminib with nilotinib or dasatinib, will that be better than a single agent?
What do we want with first line? We want to suppress BCR-ABL as fast as possible, but we don't want to induce cytopenias. We don't want to induce side effects. With the combination of asciminib with the TKI, we cannot improve tolerability because we have still the same TKI in the backbone. Therefore, if we want to improve the tolerability, then we need asciminib monotherapy. And this was, with Novartis, a big discussion. We started a combination trial 2 years ago, the Fascination trial, which combined the TKI inhibitors with asciminib. We have very good data for efficacy, but we could not improve the tolerability. Therefore, I think for the next trials, and that's of course ongoing internationally now in the Novartis trial, we have the monotherapy with asciminib. And I think this is the right direction. I would expect a much better quality of life and a much better side effect profile for the asciminib monotherapy. That's for the chronic phase sufficient. All this preclinical data, which combined asciminib with TKIs, was done in blast crisis patients and in cell lines, in blastic cell lines. And in blastic cell lines, of course, the secondary mutations are much higher than in chronic phase. Therefore, this was the first notion that it's an ideal combination. But I think the focus should be tolerability. And for this focus, we need the monotherapy.
Thank you.
One question from the audience. How do you approach a patient who cannot tolerate lowest effective dose of TKI due to cytopenias?
Repeatedly, with different TKIs. If this patient is eligible for transplant, he should be transplanted. Absolutely. That's a major risk factor for survival, for follow-up, because these patients are not able to recover the normal hematopoiesis. They have a lack of normal hematopoiesis. Either, as I mentioned, because the normal hematopoiesis is myelodysplastic, or just not existing because of a long-standing CML with a big spleen and all these severe disease situations. If this is repeatedly the case with different tyrosine kinase inhibitors, this is a cohort of patients who should be transplanted.
Thank you. Stalin, your question.
So thank you for a very lovely talk, sir. Just extension to the last question. My question was, if at all, hello, am I audible?
Yeah. Yes, you're right.
If at all patient is having a persistent thrombocytopenia with especially with the availability of generic dasatinib, we are more using dasatinib in the frontline setting. For a patient who has a persistent thrombocytopenia, even after stopping the TK, is there any role of the thrombopoietin receptor agonist like romiplastim and L-thromboplaque for the rise of the platelets?
If it's an isolated thrombocytopenia, I would do that. I have quite good experience with a 5-day per week schedule with dasatinib, because we see with dasatinib a very short half-life and we see a peak inhibition. That means we can reduce the dose by reducing the days per week. 5 days per week has an advantage for the cytopenias. And in addition, thrombopoietins may help in individual patients. Yes.
Can we use them simultaneously? So if once the platelet counts start rising, a TK with a...
No contraindication. I don't see a contraindication.
Thank you.
One more question, sir. Hello.
Go ahead, Stan.
One more question, sir. So recent WHO classification of CML has told that the major root abnormalities, if the patient have, to be placed as an accelerated phase. If at all those patient has a major root abnormalities at presentation, so will we be intended to use the higher dose of a second generation TK, like 800 of nilotinib and 140 of dasatinib?
A clear answer is no. First, major root aberrations are not the right classification. We have now changed this into high risk aberrations. High risk and major root are not identical. For instance, these 3p26 mutations, aberrations are not part of the major root because they are so rare, but they are a disaster for the patient. These patients should be transplanted very soon. The dose has little impact. More the type of the drug, I would use second generation drugs and actually I would use dasatinib. I would use dasatinib here compared to imatinib, which has a stronger suppression of the leukemic clone. But I can tell you that we are just working on the new WHO classification, which will appear in September of this year. And the accelerated phase has been cancelled. There's no accelerated phase anymore, which is much more easy for the clinician, because the accelerated phase was a mixed bag with everything. And for some patients, as you mentioned, these patients with the high-risk aberrations, they had an indication for transplant. But a patient who had 15, 16% of blasts, the blasts may have disappeared with a single tyrosine kinase inhibitors. That means no indication for transplant. That's different. Therefore, accelerated phase was skipped, was omitted. We have now chronic phase with different grading, high risk, intermediate risk, low risk, and we have the molecular aberrations, and we have blast crisis.
Thank you, sir. Thank you.
Akanksha.
Good afternoon, sir. Thank you for the comprehensive talk. So I have two questions. The first question is regarding how you manage a pregnant female in the second trimester who's presenting with myeloblastic CML crisis. And second question is that now with so many options available for first-line therapy, and you have the third generation TKIs coming in. So what would be your indications for transplant, allogeneic transplant in the CML chronic phase patients?
Yeah. Second question first. First question we need to repeat later. But second question first. We have 4 drugs available for first-line treatment. My first indication is what is available. In your country, I think for a long time, imatinib was the only drug which was available in the GPAP cohort. Of course, imatinib is a very good drug for treatment. But if other drugs are available, we should consider them as well. And I discuss with the patients the side effect profiles. I discuss the goal of the treatment. And if a patient wants to get discontinued very soon, of course, the second generation drugs are the better choice. And here, of course, we have 3 available. I don't see a major difference in terms of efficacy, but there is a difference in terms of side effect profile. And this should be balanced against that. Yeah, with very individual situation. Allogeneic stem cell transplantation in the cases which we mentioned, persistent and recurrent cytopenias, and high-risk cytogenetic aberrations, and patients who do not achieve the optimal response rates according to the ELN recommendations with at least 2 drugs.
And
what was the first question?
Yeah, the first question was regarding a management of pregnant female in the second trimester who's presenting with the first time presenting with the myeloblastic CML, myeloblastic crisis of CML.
That's the same with AML. If we have pregnant women with AML, of course, it always depends on the time of the pregnancy. That means how far is the kid, and on the situation of the AML. Of course, you need to treat with chemotherapy here, which is possible in pregnancy. Of course, you see a delay of the growth of the placenta, which is a problem. That means retardation of the child. Last year we had a woman here in my department in the 28th week of pregnancy with an AML, and we treated her with idarubicin and RRC, 1 course. And then there was a sectio. The child is okay, the mother is okay. Everybody is now 1.5 years old and everything is fine. That means it's a balance. but I would not use in CML, I would not use a tyrosine kinase inhibitor in the second trimester. I would start the tyrosine kinase inhibitor as an alternative to the chemotherapy in blast crisis in the third trimester. Most experience exists with imatinib. I'm not sure what happens with dasatinib also, but we have most experience with imatinib, which can be used in the third trimester.
Thank you so much.
One more question from the audience. Are there different adverse effects of COVID vaccination in CML patients than non-COVID?
I'm not aware of any major differences between the different vaccines and between the different tyrosine kinase inhibitors. There is no significant. There are different reports available in the literature, but not comparative. That means I have no objections against any of the vaccines. I have no objections against any of the tyrosine kinase inhibitors.
Right. Another question is, how do you choose a TKI if there is no mutation at the time of relapse?
It depends on the previous drug. If the previous drug was imatinib, of course, all the second generation drugs are an option. And I choose the drug very similar what I described in the first line situation, according to the comorbidities, according to the side effect profiles of these drugs, yeah, if there's new mutation. But in most cases, I use after imatinib, nilotinib or dasatinib, and I use after nilotinib, in most cases, dasatinib, after dasatinib. I'm a little bit cautious to use nilotinib because dasatinib is broader acting. In some cases, I use bosutinib then. That means it's very individual, depends on the previous drug. But you're right, that's a real life situation because we have now in most cases new mutations, no mutations. The mutations were a matter of 10 years ago because all patients had a long-standing disease and they had this mutation, this selection pressure, which is not the case anymore because we are now better in the suppression of the leukemic clone.
Another question is your comments about combining ponatinib with asciminib in patients with 315.
I have no experience. There's no data. We have only data on the rotation, but not on the combination. Ponatinib is a very strong BCR-ABL inhibitor. I'm not sure if the addition of asciminib will show an advantage here, but this needs to be investigated. I think the rotation of the two drugs is, for the time being, the better option because we have no pharmacokinetic overlap then.
Sandeep, your question.
Yeah, good evening. Again, thanks for excellent lecture. And we were lucky to have asciminib in few of our patients on compassionate base who have failed on all three TKIs. And these patients, if they are having persistent cytopenia, we don't know whether it is because of dasatinib or because of the disease. So what should be the dose of asciminib? We should start with the full dose or we should start with the half dose and then increase the dose?
For chronic phase, the 80 milligram.
Yeah, chronic phase.
Full dose.
Even if there is cytopenia.
Yeah, asciminib has no impact on the normal hematopoiesis. It has impact on the leukemic clone. And if it works, the worst situation could be that you have a complete cytopenia because there is no recovery of the normal hematopoiesis because there's not existing, but you want to suppress the leukemic clone. That's the reason to use asciminib. And if this is the case, you suppress the leukemic clone and you end up in cytopenia, the patient should be transplanted. There's no other choice. Because with the reduction of the dose, you have a reduced activity on the leukemic clone, but again, no activity on the normal hematopoiesis. Therefore, I would use the full dose.
Thank you. My second question is regarding treatment-free remission and restarting of the therapy. usually we have said that till you lose MMR, don't restart the therapy. But if patient is losing deep molecular response and the trend is rising BCR-able copies, then I don't understand what is the logic to wait till loss of MMR. Why can't we start early, restarting the treatment?
You know, for the studies, you need a definition. For the studies, you needed a definition, yeah. But if you see a steady rise, of course, you can restart below MMR as well. Absolutely. But then you have at least 3 time points with a steady rise, yeah.
Yeah.
You can do that, absolutely. Yeah.
Thank you. Thank you.
Vivek?
Good afternoon, sir, and thank you for the talk. I have 2 questions. One relates to the current studies. In your assessment of the data that was shown at ASH and the other work that's happening, how do you predict that the role of sequencing upfront or at relapse will increasingly influence treatment of chronic myeloid leukemias in different phases?
Yeah, this needs to be demonstrated, of course. The sequencing of the additional genes has impact in AML now. It has impact in myelofibrosis. It has already impact for CML. We see that patients with A6L1 mutations have a less likelihood to achieve an MMR. That means they are at risk. I'm not sure if we go to transplant very early. I'm not convinced about that. But at least we identify a cohort of patients who are at risk and should be observed more frequently, more stringently, whatever. Yeah, but first we need to define the real risk with this prospective analysis. And we are now in the Harmony consortium. We collect all this data together and want to achieve a situation that we have more sequencing data available and follow up these patients.
Thank you, sir. That helps. One quick question for the clinic, as in when you treat patients on ponatinib and you have to dose optimize them for non-hematological toxicities, say skin or liver toxicities, how do you generally dose optimize them? What is the dose delays that you prefer?
It depends on the toxicity. If you have a liver tox on 45 and this is reduced on 30, then of course I'm happy with 30. It depends on the severity. If you have still a severe toxicity with 15, of course you need to discontinue the drug. That's very individual, yeah.
And how frequently have you seen dermatological toxicities with ponatinib?
With ponatinib, very similar to dasatinib and nilotinib. We see not only erythema, we see acne in some patients, but it's in most, we see it frequently, but not severe, just grade 1. Just grade 1. That means not very severe, not a problem, not a major problem. Yeah, I have seen a patient, a young patient, a father with a 2-year-old kid who was new on nilotinib, and after 1 week, he had a very, very severe exanthema on the head, on the arms, on the foot. Yeah, I was thinking this is a severe Tasigna toxicity, but it was a enterovirus infection. He has infected from the kid. The kid had an enterovirus infection. The problem was in this case that he infected me. That means this was a proof. That was a proof that this was an infection and not a nilotinib side effect. That means this should be separated. I continued nilotinib and I survived this infection, but it was quite challenging. It was a real problem. You know what the most important problem was?
Yeah.
My MacBook didn't work anymore because I have a MacBook with a fingerprint. And there was no fingerprint anymore. It was all gone. Yeah.
So we'll keep that in mind, sir. Thank you so much.
Yeah, yeah.
Rishma?
Good afternoon, sir. So actually, my question is in continuation with the previous question of cytopenias. So presently, I'm struggling with the patient in whom I'm not able to get into. He's not tolerating any of the TKIs presently. I have tried imatinib, low dose decreased to 100. He goes into bad cytopenias, given a break, counters recover. Nilotinib, dasatinib, both I have tried. So my question is, if I plan a transplant, how do I get him into remission? Like, or should I transplant with disease because BCR-ABL is still 40–50%?
That's not the problem. There's not a problem at all. You can immediately go to transplant. What is needed is elimination of blasts, if you have blasts. But the level of BCR-ABL is not important for the start of transplant.
No, so
You
he
will
does
get
have
a
blasts,
risk.
but the marrow is hypocellular. Whenever I try to...
Yeah, that's okay. Then don't observe the PCR. The PCR is not important for the trigger for transplant. No, for the trigger, yes, of course, it's a non-response, but not for the eligibility for transplant. You can go strict to the transplant, stringent, without any pre-treatment. It's just of course, the high-dose chemotherapy for the transplant, but not a preparation for transplant.
Okay, sir. Thank you so much.
Not needed at all. If he has this big spleen, of course, the spleen should be reduced, the spleen size.
Yes, he has big spleen. He has around 10
Yeah,
centimeters.
that's the reason that he has cytopenic. You may discuss a spleen radiation prior to transplant to reduce the size of the spleen, but then an immediate transplant after this radiation. Otherwise, the cytopenia will get worsened.
Thank you.
Will SMA be of any help? I have applied for compassionate
No,
program.
not at all. Not at all. Not at all. It will result in an even severe transplant at cytopenia, because you have a leukemic clone, nothing else. Asciminib will reduce the leukemic clone. He will get more severe cytopenic.
Okay, sir. Thank you so much, sir.
No need to do that.
Question from the audience. What will be your approach for a 32-year-old man, chronic phase CML with 7 monosomy at diagnosis?
Transplant.
Right.
Absolutely.
Another question is there a drug interaction between ponatinib and antifungals posaconazole?
Yes, there is. There is a cytochrome. There is a cytochrome overlap.
Right. Radhika, your question.
Thank you, Dr. Andreas, for the interesting update. So I had a young pregnant female who was referred to us at 38 weeks of gestation with a high WBC count of 2.5 lakh. Later, she was diagnosed as CML-CP with BCR-ABL positive. So my question is, how do you manage such a high TLC count who presents just 1 to 2 weeks before gestation? Do we really have to cytoreduce the patient significantly before going for delivery, or safely give clearance for delivery?
Which week is it?
38 weeks, just 2 weeks prior to EDD. It's an unbooked case presented upfront.
I would reduce the
How do you
leukocytes.
How do
Yeah,
you
it's a risk. It's a risk for thrombosis. It's a risk for bleeding. I would reduce the dose. It has no major impact on the kid. You can give Hydrea. I think ideally Hydrea.
But
I would give Hydrea. You can also give RRC, and you can give imatinib. But imatinib takes some time. I would start with Hydrea here.
leukapheresis has any role here, or it's dangerous to use here?
Which one?
Leukapheresis.
Yeah, with leukapheresis, you need heparin again for the machine. Has a risk in this stage of pregnancy.
We have initiated on hydroxyurea and imatinib. We took a risk, and then we gave clearance for surgery. She did well.
No, that's fine. That's fine. That's okay.
But I was not sure how to manage this case.
No, but that's an option. It's a very good option. Yes. Delivery with 200,000 leukocytes is not the best. Is not the best option. Yeah.
We had little confusion. Should we go for leukapheresis? But then She was like heavily pregnant. So
yeah, but leukapheresis is a good option, of course, in general. But here you need a fast response because you have only 2 weeks time, and you need an ongoing response. Leukapheresis has a short-term response timing, and the imatinib and Hydrea have a prolonged response, of course. It's better.
Thank you, sir.
One question from the audience is, what is your post-transplant maintenance strategy for a patient who has CML-CP with TKI intolerance due to grade 3 cytopenia, no KD mutations? Will you maintain with interferon or TKI or PCR-based preemptive strategy?
In general, we don't do maintenance therapy if there is not a PCR trigger. Only if we see MRD after transplant, we start an inhibitor according to the sensitivity, of course, or DLI. The point is that DLI must not be used together with the TKI, because the TKIs, in particular ponatinib and also dasatinib, reduce the T-cell response. And if the T-cell response is inhibited, DLI do not make sense. Therefore, either DLI or a TKI, and if the TKI, the pre-existing cytopenias is not important, because the cytopenia is in most cases disease-related and not drug-related. Therefore, it can be used, I think, after transplant.
Thank you, sir. Is there any other question from anybody here? Sir, in that case, extremely grateful to you. That was the last question.
Oh, my pleasure. My pleasure.
Thank you very much, sir.
Nice to have such an interested and big audience here and such a good discussion. Thank you very much.
Thank you, sir. Bye-bye.
So, thank you. Have a nice day and week. I know you have many presentations this week. That's very useful. And so thank you very much. Bye-bye.
Over to Dr. Arvind.
Yeah. Good evening, colleagues. I'm Dr. Arvind. We would like to thank on the behalf of organizing committee to Dr. B Agarwal, sir, for giving us this opportunity to sponsor a session on myelodysplastic syndrome. Professor B Agarwal, sir, doesn't need any introduction. He's the president of Mumbai Hematology Group and professor and head of department at Bombay Hospital and consultant at Leelavati Hospital and Bridge Candy Hospital. Sir has been the guiding force behind putting together such a wonderful academic program, and we are really glad that we got this opportunity to associate it with Best of ASH. Without a further ado, now I hand over to our program director, Professor B Agarwal, sir, for the next session on myelodysplastic syndrome. Thank you, sir.
Thank you, Dr. Arvind. Over to my side, yes.
Thank you very much for this opportunity to be again, I guess, virtually in India. Maybe one day I will go back and visit such a fantastic country and people. I want to thank Dr. Agarwal for the invitation. My name is Guillermo Garcia Manero. I'm from the Department of Leukemia at the University of Texas MD Anderson Cancer Center, and I'm going to give you an update on what happened in myelodysplastic syndrome the last year, with an emphasis, of course, on the American Society of Hematology meeting. Just a brief introduction. I've given this talk for your group multiple times, so you are familiar with this slide, but just to remember. So we divide patients with MDS into these 6 subgroups, and this is for practical purposes. On the left, those patients with ICUS CHIP CCUS, meaning clonal hematopoiesis of undetermined potential, clonal cytopenia of unknown significance, or idiopathic cytopenia of unknown significance. These are pre-MDS conditions that we don't treat at the present time, although we probably follow them in a different way. Then we have the patients with true MDS. We divide them into lower versus high-risk disease. We used either the IPSS or the IPSS-R. So patients with low-risk disease will be low or intermediate one by IPSS, or very low, low, and some types of intermediate risk by IPSS-R. High-risk disease will be intermediate to high by IPSS, or high, very high, and some subsets of intermediate by IPSS-R. And then we further divide these patients into whether they have received prior therapy or not. If they have received prior therapy with a hypomethylating agent, then we call these patients hypomethylating agent failure or HMA failure disease. That can be low risk or high risk. The survival of HMA failure low risk, as you see in the slide, is around 14 to 16 months, and for high risk is around 4 to 6 months. And then at the end of the spectrum, on the right, you see those patients that transform from NDS with a history of acute myelogenous leukemia that have very poor prognosis. I'm not going to talk about them. This is a summary of a treatment algorithm for our patients. Again, divided them into lower risk versus high risk disease. For lower risk, we have a number of supportive care options, including iron chelation, growth factors, in particular erythroid growth factors, luspatercept, that is this TGF-beta modulator, recently approved in the United States for patients with ring sideroblastic anemia after an ESA failure. We use hypomethylating agents, usually at a lower dose, either decitabine, azacitidine for patients with bicytopenia, of course, lenalidomide for patients with del(5q-MDS. And then there is the rare subset of patients with hypoplastic MDS that looks very much like aplastic anemia that we treat with ATG cyclosporine L-Trombopac. Patients with high-risk disease is a little bit more complex, and you look at the age of the patient, you look at whether the patient is a candidate or not for transplant or maybe for induction chemotherapy, and then you're going to make a decision based on those concepts. With that, let's start with the data. So this presentation by Dr. Díaz-Campello from Spain is actually from the ASH 2020, so it's a year old. There were no updates, but I think it's a very important piece of information. This is the so-called Sintra-REP trial. This is a study for patients with del(5q-MDS that were transfusion independent. And these patients had a randomization between low-dose lenalidomide, 5 milligrams daily for 2 years versus placebo. And the objective of the study was to measure how long they remain transfusion independent, in other words, the transfusion-free survival. And the data is very positive. This is an interim analysis, so it's not a full analysis, but what you see there is that the transfusion-free survival was 6.3 years versus 2.8 years for those patients that started the lenalidomide later. So you double the amount of time that your patient remains transfusion independent. The other issue that this investigator showed was, of course, a very high rate of cytogenetic responses, so the chromosome 5 disappeared. We don't have data on the impact of this intervention on overall survival, but I would think actually that the survival eventually, with a few years of follow-up, probably will be in favor of the intervention. Why I think this is an important study is because I think this basically attests at the potential role of what I call a preemptive or early intervention in myelodysplastic syndrome. In other words, start therapy before these patients get worse. So it's going to be very interesting to see what happens to this study with more follow-up. The other presentation of interest was that of oral decitabine in low-risk MDS. So this is the schema of the ASCERTAIN trial. This is a study that I led. This is a study actually that led to the approval of oral decitabine in the United States. This was a randomized phase 3 trial looking at PK/PD profile of IV decitabine versus this oral decitabine cedazuridine. The study was positive based on PK/PD, and that's why the drug was approved. But we were interested in understanding perhaps a little bit better outcomes of patients with lower risk disease, in this case by IPSS. So it turns out that there were 69 patients on this study with low risk disease. The complete remission rate was 23%. The overall response rate was 39%. So this is really nice figures with an oral compound. Remember that here we were giving 5 days of the oral decitabine. When we look at the rate of transfusion independency, it was 48% for red cells and 67% for platelets. Again, really nice numbers. And then when we look at the rate of or the survival with a follow-up of around 32 months, this has not been achieved. So again, we saw no mortality. We saw rate of transfusion independency was quite satisfactory and a significant fraction of responses. Now we're now conducting a clinical trial with oral decitabine, but using 3 days instead of the 5 days to see if we get even less toxicity and more responses with an attenuated type of approach. There was another interesting presentation from Dr. Gonzalez Lugo, where he combined lenalidomide with El Trombopac. And here the idea was that thrombocytopenia, we know, is a potential side effect of lenalidomide, and perhaps by combining with El Trombopac, you may get also some benefit in terms of recovery of platelets. So they had a little bit of a complicated scheme, as you see here, depending on the platelet threshold and so forth. The authors showed that you could combine El Trombopac with lenalidomide, but I'm not sure that the responses that I'm seeing here are really exciting and very different from single-agent lenalidomide, or even actually from what I read a single-agent El Trombopac. That said, it's important because we're starting to see a interest on the use of thrombomimetic agents in myelodysplastic syndrome. And then there was not a lot of data at this ASH meeting, but just to refresh our memory, that luspatercept, that is now approved for second line, is being studied in front line in the so-called COMMANDS trial, randomizing low-risk MDS to luspatercept versus an ESA. Imetelstat is a telomerase inhibitor that is actually completed a phase 3 trial post ESA failure. Rosuvastatin is a HIF-1 alpha inhibitor. And as I mentioned a second ago, there is now a re-emergence of interest on these thrombomimetic agents. Let's move to high-risk disease. There are a number of very important presentations at the meeting, some of them disappointing, some of them potentially of great interest. So let's start with the first one. This is the so-called Panther trial, or PIT 3001. This was a major presentation by Dr. Sequeres, and we were all a little bit disappointed by the results. So this study randomized azacitidine to pevonidostat, or azacitidine alone. It came after a phase 1 and a randomized phase 2 studies by Dr. Schwartz and Dr. Ades that showed very positive data. So this is a very powered study, 454 patients with high-risk MDS, CMML, oligoblastic AML. And the endpoint was event-free survival in the intent to treat population. So there was a lot of expectation on this study. Unfortunately, what we saw was when we look at the response rate, so we're going to focus on the ITT population on the left, there was actually no benefit in terms of response to the doublet versus single-agent azacitidine. It is also noteworthy that actually the complete remission rate with azacitidine in the study was actually 31%. That is one of the highest that we have ever seen. So that's also very peculiar because it's done in the context of a very large multi-center, multi-country trial. Unfortunately, we did not see a benefit in terms of survival. Again, the study was powered for EFS, and you see basically that the EFS was identical between the doublet versus the single-agent azacitidine with a hazard ratio of 0.96. In terms of survival, maybe a trend towards perhaps improved survival with the doublet, but again, a hazard ratio of 0.88. So unfortunately, the study was negative. The reasons why this happened are still not clearly understood. I'm sure that we're going to see a lot more data trying to give us light in that sense. The next study of interest that was also a negative study is the combination of APR and 246 and azacitidine. APR 246 is a prodrug that eventually binds to the p53 protein. So we had performed phase 1-2 studies of this combination with nice activity in patients with p53 mutated disease. So this is actually specific for p53 mutated patients. Subsequently, a phase 3 study was performed. I was part of the leaders on that study, and we have not seen the full data, but a report has indicated that the study was negative. This is a press release. At ASH this year, Dr. Salman, who is the leader who developed this compound, with the French group, with Dr. Clouseau, put together the results of 2 phase 2 studies that were conducted in parallel and eventually published in the JCO last year to better understand the dynamics of the activity of this doublet. So combined, they have 100 patients. They report an overall response rate of 69% with a CR rate of 43%. And 40% of these patients achieved a molecular response. So these are very powerful numbers. When we look at the overall survival, it's around 11.8 months. That is not clear to be better than single-agent HMA, but that's of course questionable. Interestingly, as I mentioned earlier, there were a fraction of patients that achieved molecular responses, and those patients that achieved that kind of response had a better survival, 15.8 months versus 10.1. But what I think the data from this presentation is quite interesting is from the transplant impact. So this is a landmark analysis looking at transplant, yes, no, on the left, and there's no benefit. But when we see, or we dichotomize patients into whether they had transplant, yes or not, and actually they had achieved a response or not, we see that the outcomes are significantly better in those patients that were transplanted in MRD negative disease. And you see that in the green curve. Very, very important data. And it goes back to this concept of what is the best time and optimal time of transplanting these patients with adverse features. The next doublet of great importance is that of venetoclax. Of course, this follows the lines of the Viale studies in AML. This is the phase 1 study. Here, important, we only use 14 days of the venetoclax, not 28 days like in AML. The study that has been presented multiple times at ASH and EHA. This is the latest update. The overall response rate was 84% with a CR rate of 35%. We see myelosuppression in the form of pneumonia, things like that, but the mortality rate with prophylactic antibiotics and so forth is low. They didn't give us a survival for the whole group, but what we're seeing is that those patients that achieve a CR or an MCR and HI actually have not achieved a median survival. So we see depth of response, and now we're starting to see responses that appear to be actually longer than expected compared to single agent HMA. So there's a study known as the Verona trial that is a randomized study of ASA with or without venetoclax that hopefully will give us a definitive answer and maybe the approval of venetoclax for these patients. Next, I'm going to give you experience with 3 other trials outside this phase 1 study. The first one is the experience at Moffitt Cancer Center by Dr. Rami Komrokji, my dear friend. He looked at 35 patients that had received venetoclax in first line and compared that with a cohort of 1,100 patients that had received single-agent azacitidine. As you can see there, the overall response rate was 77% versus 40% for those patients that received the doublet versus the single agent, and this was highly significant. But what is of interest is that when he looked at the survival, there was no obvious difference in terms of survival for those patients that received the doublet or not. So we need to understand this data better. At MD Anderson, we have conducted 2 phase 1 trials looking at venetoclax. The first one was presented by Dr. Bassinet. This is a phase 1 trial of ASA plus venetoclax. We've looked at different doses and schedule, and we have 2 cohorts, a frontline cohort and a relapse refractory cohort. What Dr. Bassinet reported is that on the frontline cohort, where we had 10 patients, the overall response rate was 91%, but the CR rate was low, 18%. And this is due to the fact that there was so quite a bit of myelosuppression. Right now, we don't know what is the proper dose of venetoclax based on the studies. When you look at the survival, this has not been reached with a follow-up of around 15 months, and the expectation of survival at 1 year was 71.4. I will follow on the relapse refractory study later on during this talk. The other important presentation was from Dr. Benagopal, also from my department, where we have developed a phase 1 trial of oral decitabine cedazuridine with venetoclax. Of course, a total oral therapy will be of great interest for our patients. So here we're looking at the doses of these 2 compounds that again form a total oral approach. The number of patients is small, 9, but basically the overall response rate is 100 with a CR rate of 33%, similar to what Dr. Komrokji and the phase 1 trial had presented. Now the follow-up is short, around 7 months, but median survival has not been reached, and the 6-month survival is 100%. So this appears to be a potentially doable, very effective combination, and we will follow up once we have more patients. Next, I'm going to discuss some forms of immune therapy for patients with MDS. This is a schema of things that we could target, in particular, actually anti-CD47 checkpoint in macrophages that is emerging as a very effective therapy for our patients. And of course, the TIM3, that is what we're going to be discussing in the next slide. So TIM3 is an immune checkpoint for T cells, also present in the leukemia stem cell. We're part of a number of studies known as the Stimulus trial, where we use sabatolimab with a hypomethylating agent. You see different doses and schedules. The response rate here is lower than what I've shown you, with a CR rate of around 19%, so not very high. But we see that the duration of these responses is quite significant, reaching now 20 months. This drug is very well tolerated. Of course, the other form of immune therapy that is really interesting is that of magrolimab, or the antibody against CD47, led by Dr. Salman from Moffitt. This data has not been updated since the original presentation at EHA a couple of years ago, but what we know is that this is highly effective with a response rate of 92%, CR rate of around 50%. Of course, we are eager to see follow-up and longer follow-up with these responses. There's been interest also on developing other anti-CD47 antibodies, and an example is this compound known as evorpacept, or ALX148. Now, this was a poster, was not an oral, but along the same lines that we saw with the magrolimab, in patients with P53 very complex karyotypes, we see responses that were around 50 to 60%, and a fraction of these individuals going into a stem cell transplant. Now, what is different from the ALX and the magrolimab is that ALX does not have the hemolytic anemia that is not uncommon in patients that receive magrolimab during the first couple of cycles of therapy. And then one word for high-dose chemotherapy in high-risk MDS. This is something that is now starting to come back. In my place, Dr. Kantarian is talking a lot about this. And this is actually something performed by Dr. Fenot and his group, presented by Dr. Peterlin, looking at CPX-351, a compound big cells that is approved for acute myelogenous leukemia, elderly, secondary, etc. So these investigators in France are looking at this compound as a kind of bridge to transplantation. That's my understanding. So they gave up to 4 cycles of this therapy. I think this is actually kind of hard to do in regular myelodysplastic syndrome. But the overall response rate is 90%. And if you use more conventional, easy kind of ELN 2017 criteria, the complete remission rate is 52%. So it seems that this could be a very good option to take someone to transplant with high-risk myelodysplastic syndrome. People are also talking about triplets, just to discuss this briefly. We don't have those in MDS yet. I'm just going to briefly mention in AML an example. This is actually a study of azacitidine with venetoclax and APR as an example of triplet. People are investigating this with magrolimab, such as Dr. Daber in my center, or with sabatolimab in studies that are being now developed. The data that we saw was an overall response rate in P53 mutated AML of 64% with a complete remission rate of 40%. So it's going to be interesting to see what happens with the magrolimab trials and so forth. The survival is still limited, around 7 months, so we need to understand a little bit better what happens there. Next, we're going to move to HMA failure. There is not much at the meeting this year or last year. There's some data with venetoclax, maybe some data with CPX-351, and I'm going to mention briefly eltanexor. So this is actually a representation of a poster that we presented 2 years ago at ASH by Dr. Seidan on a multicenter clinical trial, where we basically added venetoclax to patients with HMA failure disease. What you see here, the response rate is low, 7%. The overall response rate is around 39%. And then when we start looking at the median duration of response, it's around 9 months. So it is possible actually that this may be associated perhaps with a slight increase in survival in our patients. So we have to follow more on this data. At MD Anderson, if you remember, I was telling you about the study from Dr. Bassinet. That study, phase 1 trial of ASA with venetoclax, had an HMA failure cohort. You see that here, small number of patients, 6, but their overall response rate is very high, 100%. But most of these people achieved what we call a marrow CR. Now, the survival of this group of patients with HMA failure in red is around 10.5 months. That appears to be a little bit longer than what we know, for instance, from the rigosertib trial, with around a third of these patients alive at 1 year. So these are modest numbers, but we will be interested in understanding a little bit better what happens here. Dr. Montalban Bravo, together with Dr. Rivera, are studying, this is at MD Anderson, CPX-351 for HMA failure. They're conducting a phase 1 trial. They went all the way to 75 units, but most likely we should be a little bit lower than that. In our experience, this is toxic in this context of HMA failure disease. But what you see here is that there's actually a very high rate of responses, although none of these individuals really achieve a complete remission. We're now expanding the study at a lower dose of the CPX, but this could be an appropriate salvage program for our patients. The survival is around 13 months, so that's actually kind of positive, with a median follow-up of around 14 months. So we need to get a little bit more information in what is the impact of this study in the natural history of this disease. And just to mention that at EHA in 2001, there was a report of this compound known as eltanexor. This is a drug that inhibits transit through the nuclear membrane. And these investigators are using different doses. They're reporting overall responses that are between 60 to 50%. MD Anderson is now part of a phase 1/2 trial of this compound for HMA failure disease. Finally, I'm going to talk a little bit about targeted treatment in myelodysplastic syndrome, and I'm going to focus on these 3 mutations, IDH2, 1, and FLT3. So first of all, this means that both at the front line and at the relapse refractory situation, you need to have some type of genomic testing to really have an opportunity to treat your patients. This is the pathology report at MD Anderson. First, I'm going to show you an example of the activity of IDH2 therapy in patients with IDH2 mutated myelodysplastic syndrome. This was also presented by Dr. Benagopal at the EHA meeting last year. And the study has two cohorts, an untreated cohort and an HMA failure cohort. In the front line, the response rate in combination with azacitidine was 84%. In the HMA failure, 43%, not very active. When we look at the survival, again, with a follow-up of around 11 months, the median survival has not been reached, and the expected at 1 year is 76%. But what I find very interesting is the numbers at the time of HMA failure, where the azacitidine by itself as a single agent is associated with a median survival of almost 22 months in HMA failure disease. We have never seen these numbers, and this is extremely well tolerated. The French are following up with a study known as the IDEAL study. This is led by Dr. Ades. Again, they use an azacitidine single agent or in frontline with or without azacitidine. So it's a little bit of a complex analysis or study. The rate of responses that they're showing is a little bit lower than what we saw in the study of Benagopal and Dr. Dinardo, but again, quite significant. And then for those patients that respond, they have a nice rate of response or duration of those responses and potentially survival. They're also in France doing a study against IDH1 mutated MDS that happens in around 5% of the patients. This is the so-called IDEOM study. This is for IDH1. The rate of responses are higher, as you can see here, as high as 90%. But I'm not sure what these survival rates are. My understanding is that the follow-up is short, the amount of patients is short, but basically our experience both in IDH1 and IDH2 mutated MDS is that the inhibitors with or without actually venetoclax can be quite effective. It is also important to realize that a fraction of patients are positive for FLT3 mutations at the time of HMA failure in MDS. And we've been targeting this with different compounds, for instance, sorafenib with Dr. Ravandi, and more recently, Dr. Abusab and Dr. Montalban Bravo have developed a clinical trial of quizartinib as a FLT3 or cis-CBL inhibitor in MDS. This is a phase 1 study. And what they reported in this poster at ASH is, again, a very high rate of response using quizartinib or AC220 in this context. So I think that for a patient with HMA failure with some degree of leukocytosis, it will be important to check for the FLT3 mutation. It can happen in around 15 to 20% of the patients, and then consider adding some FLT3 inhibitor. Probably in my experience, gilteritinib will be potentially the best agent, but the data that we have is with quizartinib. And then one word on transplantation. I think this is very important. This is data again from ASH 2020, published this year in the JCO by the IBMTR and Dr. Nakamura. But basically what we see here is that now we started to see survivals with transplantation that are actually over 40% for donor, over 20% for unrelated. This is now a 21% absolute improvement over the years. And at MD Anderson, we're starting to transplant people over the age of 75. So this is great news. If you remember the data I showed you early on with APR246, it looks like now if we have good therapies that can give us a molecular response, we could be in a situation where we could start curing a fraction of these patients if we are able to bridge and incorporate transplant in the proper fashion. And with that, I would like to finish this presentation. I want to thank Dr. Agarwal always for his great opportunities. My summary for today's talk is that for low-risk MDS, again, you have early intervention with low-dose lenalidomide. That's very important. The new data with the oral HMAs, that's very important. If you don't have that, of course, you can use low-dose decitabine, low-dose azacitidine. For high-risk disease, we discussed multiple doublets. The question is, why did Panther fail? I don't know, but we still have the Verona, the Enhance, and the Stimulus. So Verona is for venetoclax, Enhance is for magrolimab, and Stimulus is for sabatolimab. For HMA failure, not a lot. So we have the data with venetoclax, with the CPX, but we need more. And please do not forget testing for molecular alterations, particularly NPM1, IDH2, IDH1, FLT3, CBL. And then I think that outcomes with transplantation are improving and that we may be able to somehow provide and deliver a kind of total therapy for our patients. And with that, I would like to finish and thank you very much for this opportunity.
Thank you, sir, for that lovely presentation. We have now Indian faculty here. They may be interested in asking you some question. I have one question for you at the moment. What is the best option in the clinics for TP53 mutated patients?
This is a very difficult problem right now. Thank you, Dr. Agarwal, for inviting me and also for allowing me to pre-record, because where I am, the internet is very unstable and in person will have been difficult. As I told you, it's strange to hear myself. Anyways, going to your question, I don't have a good solution for the P53 right now. The best option is hypomethylating agent. That's better than chemotherapy. So it's azacitidine or decitabine. It is unclear if venetoclax helps or not. Of course, in AML, it doesn't look like the venetoclax adds to the P53. The question is, does it do any damage? Probably not. At the presentation attached from the phase 1 trial of ASA venetoclax that I was part of, we saw nice response rates with ASA venetoclax for P53, but it is unclear that this really translates into better survival. So right now, outside clinical trial, I think you are a little bit stuck with the single agent HMA. And indeed, actually, sorry, this is long answer. If you look at the phase 3 trial of the APR246, that was reported on a press release in 2020 December, the data actually look good with the single agent HMA, and a fraction of these people can be transplanted. So this is the best I can tell you right now. HMA, some patients may be venetoclax, I'm not sure. And then the transplantation in this context is also depending on what type of response. And for sure, if you take a patient like that to transplant, you want to really consider post-transplant HMA in those patients because they have a high rate of relapse.
Thank you, sir. Stalin, your question.
So thank you, sir. That's a nice talk. So for a MDS high risk who is transplant ineligible, is there any maximum duration of azacitidine until which we can give and stop the therapy after some point of time? And we now had a availability of various generic oral azacitidines. If the patient is on azacitidine injectable till now, can we change the form of therapy to oral?
Okay, so these are two questions. So the first one is the duration. So when we started developing the decitabine and the azacitidine, like around almost 20 years ago, believe it or not, I was a young assistant professor, not like now. We designed the clinical trials to give therapy for 2 years. And then in those studies, they're both published in Blood long time ago, we saw actually that most patients that had a CR that stopped therapy relapsed. So one of my fellows around 10 years ago wrote a study combining our experience in patients that had had a very good response to HMA where we stopped the therapy, and we saw that most patients relapse. So we have always asked this question of continuing therapy for as long as possible. And indeed, one of my colleagues at MD Anderson, Dr. Simona Cola, wrote a very important paper in Cancer Cell, so this is very important journal, around 4 years ago, looking at the stem cell of the MDS. Now, she did that in animal models and then in some human experiments. And what we found is that the azacitidine or the decitabine do not kill the stem cell of the MDS. Indeed, what they do is somehow they allow the stem cell to differentiate and maybe give you good white cells, red cells, platelets. But the stem cell, if you do like single cell analysis, for instance, is always there. And I think that's why these patients actually relapse. So, I know in some countries, I'm not saying this is the case in India, but, sometimes places like South America, things like that, this is very expensive and the patient may not be able to do that. Is a problem. But you should try to maintain the therapy for as long as possible. And then I think you asked about the oral hypomethylating agent. Of course, I don't see a problem with that. Now, you have to see that right now, the only oral hypomethylating agent for MDS is the oral decitabine cedazuridine, not the oral azacitidine. So I can go over that if Dr. Agarwal wants me to expand on this. So we understand the dose of the oral decitabine cedazuridine very well. It could be 5 days, it could be 3 days, it's 1 tablet a day. That will be very simple. We are doing this in a lot of patients. Patients, particularly with the COVID, are loving going from IV subcutaneous to the oral medication. Is much better for them. Now, what about the oral azacitidine? This is a drug that is very dear to me because I developed it from the phase 0 trial. This has been like 20 years of my life. As you know, this drug is approved for AML, and I'm very proud of that. New England Journal paper, very important. But we don't know the dose and the schedule of oral azacitidine in myelodysplastic syndrome. In the study that I published, I think 2 years ago in the JCO with the randomized study, we had used a very large dose, maybe 14 to 21 days. That was too toxic. So, the oral azacitidine provides a very low exposure. So it's a little bit complicated right now to tell you 100% what will be the proper dose of the oral azacitidine for our patients. So if you're going to use an oral hypomethylating agent, if you have access to that, I will consider maybe for now the oral decitabine, cedazuridine, the Incovi. We are planning studies with the oral azacitidine to see if we can go back to a dose schedule that could be beneficial for MDS patients.
Thank you, sir. Thank you.
In the paper that you published for the low-risk MDS with oral azacitidine, neutropenia was a problem. So if there is no neutropenia to begin with, can those patients be treated with oral aza?
Yeah, that's the issue. So, and then I see Dr. Agarwal, a very nice question about the 5 to 10 days. I will also answer that. That's the problem. That is, when we developed the oral azacitidine, if you look at my first JCO paper on this topic, it's like around 10 years ago. We described 7 days of the oral AZA. It worked really well. I still have a couple of patients that are 12, 13 years later on this oral AZA. It's like fantastic. Then, for reasons not clear to me, the sponsor, Pharmion Celgene, they insisted on 14, 21-day schedule. I don't know why. And that's when we saw this toxicity. Then for the AML, they did only 14 days. So if you have the oral azacitidine in India, I guess you could go for a 7-day schedule of this drug. I will not do 14 days. That's what happened. We saw some patients becoming neutropenic, some early mortality. So this drug can be a little bit myelosuppressive if you give it for like 21 days. I think this is a mistake. Indeed, Dr. Agarwal, I think that if we have done the studies with 7 days, this drug will be approved today for MDS. This actually is very sad to me. Then the second question that Dr. Jandial is asking is 5 to 10 days. Yeah. Okay. So the Washington University group, my friends, and this is like the best leukemia program in the United States, published this very good paper with 10 days in P53 mutated MDS AML, something like this, with very high rate of response. And then we wrote a letter to the New England Journal with one of my fellows, then faculty, Dr. Montalban Bravo, where we say that there is really no 5 to 10 days. It's not clear. What is clear is that the HMA, as Dr. Agarwal was asking me at the beginning, works in P53 mutated disease. If you have a patient with borderline AML, maybe a little bit proliferative, things like that, you may want to give 10 days. There is nothing wrong with that. For a regular patient, 5 days probably is enough. And again, you probably are only going to be able to give 10 days only one time, like only one cycle. I will be surprised if you can do second cycle, third cycle, 10 days. This is actually in time very myelosuppressive. These are cell cycle dependent drugs. Eventually, they get into the stem cell. And so, yeah, you could do 10 days to start if this patient has, 19% blast and the white count is a little bit on the high side. There's nothing wrong with that. But there is really no data to suggest that 10 days versus 5 is better in the long run in terms of overall response rate, survival, and things like that. I think the message is the chemo. Chemo doesn't help here. Like if you give induction AML, you just make these patients kind of sick. Unless you're talking about young patient that you're going to take to transplant a month later, where you can do like FLAG, IDA, BEN, or something very aggressive, and then a month later you go for transplant. But for most of our patients, this probably makes no use, the chemotherapy, and then either 5 or 10 days, the cytarabine is a cytarabine will be fine.
And oral AZA for 1 week, 200 per day or 300 per day?
No, the same dose as, I don't know the dose top of my head now, you got me like off. Whatever dose is approved for the AML trial, I will use, but I will only do 7 days, Dr. Agarwal. I will not do 14 days or 21 days. We had great experience with 7 days in the past. That's my own personal experience published in the JCO 10 years ago.
Thank you. Dr.
For MDS, for AML, a different story.
Right. Kungar, your question.
Yes. I want to know the role and efficacy of magrolimab, anti-CD47 in MDS, in monoclonal antibody, yes. Anti-CD47.
Thank you, sir. So I don't want to give you suspense, but you have to wait for the ASCO meeting. I believe, or EHA meeting, one of those two, I know there is going to be an important update from the ASA magrolimab. I don't want to disclose data that I know that is not public. That would not be fair. So right now, the only data that we are aware, and I'm an investigator on this trial, was the original data presented at EHA in Amsterdam, I think 2 or 3 years ago, by Dr. Salman, where he showed a very high rate of response, over 90%, with a CR rate of around 50% or so. So very powerful numbers. But again, this was an early phase 1 trial. This is a very powerful combination, but I ask you to wait for the update at EHA ASCO, where I understand that there's going to be an update on this data. And we are all looking forward, because this, of course, is going to be one of the most promising combinations, but we need to wait for those results. This drug is not approved, so we have to really wait for the update at the meeting. There was no data presented at ASH with any update. So, there was no new data from the magrolimab at ASH this past December.
Thank you. Rishma, your question.
Good afternoon, sir. Very nice and lucid presentation. So my question is for MDS with fibrosis. So I had a patient who was having myelodysplastic syndromic features on the marrow aspiration, and there was a fibrosis with a splenomegaly. We tried AZA, it didn't help. She went into very bad cytopenias. Len again was tried, very bad cytopenias. So what is the management like? How do we deal with such kind of patients?
Yeah, this is very difficult, Dr. Roshan. First of all, statistically, these patients tend to be P53 mutated. So there are two possibilities on this group of patients. So we know from all Italian studies that fibrosis is usually seen in the context of P53. Sometimes you cannot recover the cytogenetics because of the fibrosis, but you could stain the bone marrow for P53. That could give you an answer in that regard. So this patient either had P53 mutated disease with complex karyotype, or maybe is actually an MDS MPN that is evolving, maybe JAK2 mutated, maybe that could be also explained by the splenomegaly. These patients do poorly. That's the reality. This is a very difficult group of patients. So, and even if they respond to the HMA, many times these responses, unfortunately, are short-lived. So an extreme, if you allow me, Dr. Roshan, is the reverse. It's an MPN that transforms into high-risk MDS or AML with fibrosis. They actually can respond to the HMA for 1 or 2 cycles, but then they very quickly go transform, and unfortunately, many patients succumb to the disease. So this is particularly difficult group of patients. And again, they don't do that well with chemotherapy either. Now, if it's younger patient where you say, maybe I can take this patient to transplant 4 to 6 weeks later, something like this, you could give high-dose chemo and hope that you can take this patient to transplant in aplasia or something like this. But this constitutes a really difficult group of patients.
Thank you. Dr. Radhika.
Thank you, sir. That was an interesting update. This is with regards to one of the trial which you have mentioned, wherein Len plus eltrombopag has been used in low-risk MDS with thrombocytopenia. So my question is, sir, what was the dose of eltrombopag initiated on? It's mentioned as 100 to 300. So is it we started the dose at 100 and then escalated to 300? Or?
I don't know, Dr. Radhika, that I will be very keen to use this combination. I don't know that this is very interesting. I'm going to tell you where I use the eltrombopag, if you allow me. It's basically in the group of patients with hypoplastic myelodysplastic syndrome or in aplastic anemia. These patients are very active, very sensitive to this particular compound. I tend to escalate the dose because, as you know, one side effect that this drug has is actually fatigue. So I start at 50 and then I go up 75, 100. I very rarely go beyond 100 in my experience. They tend to respond, but it's in this context, aplastic anemia, where this drug is a standard of care, and the hypoplastic myelodysplastic syndrome. I didn't think that this combination presented at the ASH meeting was that interesting. That said, there's now a revival of trying to design a new generation of thrombomimetic trials. There are a couple of new drugs that maybe are a little bit better than what we have, particularly for the subcutaneous weekly the Nplate compound. We'll see. I don't know if this is very interesting, in my humble opinion, combination lenalidomide with the TPO mimetic. I'm sorry.
But sir, in certain MDS cases with thrombocytopenia, we in routine clinical practice, we do use add-on thrombopoietin agonist, whether it's a ROMI or an L-Thrombopac. How
Yes.
long we are supposed to continue this TPO agonist?
So this is very good question. First of all, as you know, this drug can be associated with fibrosis of the bone marrow, and there are some reports of transformation to AML. So you should really use these thrombomimetic agents in really situations where you don't have anything else to do. That's at least what I do. So you are correct that there are some patients that are very thrombocytopenic where you're desperate and you do these compounds, but you have to be careful about the fibrosis and potential transformation. We were part of all the original studies that basically were not positive in general. You could argue that those studies maybe were designed in a little bit of a different way, but I have a couple of patients from those trials that are still on therapy. And I have one on Emplate that is very interesting that has been on therapy for like 10 years, believe it or not. And around a few years ago, he was part of a trial. And a few years ago, I tried to stop the drug because we don't know. And he actually kind of lost the response very quickly. But this is an N of 1. And I see around 200 new MDS patients a year. So it gives you an idea of how rare this is.
Can I ask one more last question, sir?
Go ahead.
What is the indication for allogenic stem cell transplant in a low-risk MDS? Upfront allogenic transplant in a low-risk MDS.
Yes, so this is fantastic question. First of all, I think that all young patients should be evaluated for transplant as soon as they come. It's interesting, I saw a patient from Philadelphia, a very famous place, and the doctor was giving me a hard time. This disease is a little bit unpredictable, and waiting can be sometimes complicated. So if I see young patient, I refer to transplant. I like to know the donor status, etc., etc. So if they say no donor for whatever reason, then okay, no donor. But most of the patients right now, at least in the United States, have some kind of a donor. The question is how good or bad. To your specific question, you can address this two different ways. This is really dear question to me, so bear with me. One is that we published a paper a number of years ago with the so-called poor risk, low risk group of patients. So we developed a very simple model that allows you to predict kind of poor behavior in lower risk disease. So this could be a subset of patients that you could say, well, this is young patient. We know that the survival is not going to be 10 years. Why not transplanting now? The second is actually patients with a lot of mutations. One of my colleagues published a paper a few years ago showing that if you have more than 2 mutations, so 3 or more, prognosis is as bad as having a P53 mutation. So you could argue that. So for instance, as an example, I have a patient that I was talking to yesterday who had aplastic anemia for like 10 years. And then the doctor retired, came to me, and now this poor man has transformed to MDS, low risk, transfusion independent, no blast, but incredible, he has like 10 mutations. So I said, like, I don't know how this can happen, but I know that I cannot cure you. And he's young, strong man, has a very good donor. Like, why not just get over this? So I think right now there are no good guidelines in terms of who is a good candidate. In general, older patients with low risk disease, the mortality is too high. You need to look at the donor. But I think younger patients with kind of like poor risk features, either mutations, or if you look at the old MD Anderson model, some poor risk features, you should be kind of on top of this in the sense that maybe not transplant right away, but have a low threshold to take someone to transplantation. So to finish this long answer, I'm going to give you one very important example, very, very important. That is, there is a group of patients with MDS that develop what we call clonal evolution. So let me give you an example. Let's say the patient has a trisomy 8, low risk, transfusion dependent, perfect. And then you repeat a bone marrow a couple of years later, and now this patient has trisomy 8 plus a del20. And then you say, oh, the del20 is good, trisomy 8, del20. Well, we analyzed this data, and these patients actually transformed to AML 6 to 8 months later. So it's like a universal predictor of transformation. And then the group at Dana-Farber had almost identical data. So for instance, that's another thing that I do. You know, I may repeat bone marrow once a year, something like this. And then if I see any molecular, you know, by NGS or cytogenetic switch, because I already look at the donor, I say, you know, why to wait? This may not be 100% statistically correct, but if you have like 40-year-old person with this disease, why do you have to really risk it? So I will transplant someone like that. But of course, there is a subjectivity there.
Sure. Thank you, sir.
Question from the audience. MDS, RARS, SRSF2 mutation positive, no response to EPO and LEN. What would be your next line of treatment?
I mean, in the United States, luspatercept, assuming that there is no excess blast or some weird chromosome or mutation, that will be the next standard of care. If you don't have luspatercept, this will be a candidate for low dose decitabine, like 3 days, low dose azacitidine 3 days. If you have, I don't know about the oral azacitidine, but you could do like a low dose HMA, but I will inquire about the luspatercept. That could be a potential patient for luspatercept.
Thank you. Another question is MDS EB2 transplant fit, initial induction therapy of choice. 7+3 versus AZA plus when, azacitidine alone or decitabine 10 days.
I will need to know the age of the patients, the chromosomes and the mutations. You have to tailor this for the patient. So let me give you a couple of situations very quickly. Let's say young patient with MPN1 mutation. This actually is very rare. It's maybe 1 to 2% of the patients, but I see 1 or 2 a year. And actually the first one I ever saw from India, very nice friend of mine now. These patients are cured with chemo followed by transplant. So I will do like in that situation, you will do like a 7+3 followed by transplant. In the other end of the spectrum, you have complex karyotype, P53, older or not a good donor, you probably will do an HMA. So that's basically the spectrum. If you are diploid, good mutation, then chemotherapy is okay. If you have complex cytogenetics, bad mutations, the chemo is not really going to help you.
Right. There's a question. Your experience about HMAs in patients of MPN MDS or MDS with fibrosis?
Okay, so the MDS MPN, not the fibrosis, so let's differentiate. So MDS MPN, like MDS MPNU, for instance, we published this with Dr. Berstov 6 years ago. They behave like MDS. So the rule there is MDS MPNU, they come to MDS. So you'll do the same as a regular MDS. Those with severe fibrosis, we discussed with your prior colleague, Dr. Rona. Those are complex. You need to look for the P53, etc.
Right. Should NGS be done for all patients upfront at diagnosis?
Absolutely. And at the time of relapse, absolutely.
Is CD47 expression higher in TP53 mutated MDS?
No. The CD47 is universally expressed, so you cannot use this as a biomarker of response. Remember, this is a checkpoint of the macrophage, so we all have this stuff.
Azacitidine versus decitabine in TP53 mutated MDS. Is one better than other?
No.
Nothing of that sort.
They are both equally. Yes.
No other question in the question box from here. Anybody? Any question? Right. I think that's it. That's yeah, Reshma.
So just the small question, is there a role of flow cytometry at diagnosis or at relapse? If we are not considering the progression to leukemia, is there any role of flow in MDS as such?
Yeah, this is a very good question, Dr. Roshan. Our pathologists at MD Anderson, they use flow more and more to kind of support their morphological diagnosis. I don't know why, because in the old days, we used to run an international meeting at MD Anderson and the Italians would come and the pathologists were very, very good. And, they'll say, why do you need all these tools? So I don't really know that we need flow cytometry, but I see more and more my colleagues kind of using the flow to maybe support their visual morphological assessment. I don't know why this is really happening. It's not part of the diagnostic criteria. We still count blast by the naked eye. Some of them, depending on the quality of the marrow, they use the CD34 staining to count blast. This actually irritates me, to be honest, because I'm like, it changes the classifications, but, I see them using this flow and sometimes the immunohistochemistry stains.
So in young female patients where one of the differentials of cytopenia is an autoimmune cytopenia, and there is some
I cannot hear Dr. Agarwal. I don't know if it's me or Dr. Roshan. I'm sorry.
Dysplasia on the marrow. How do we go about? And just
Rishma, repeat your question. We could not hear you.
Yeah, yes, sir. If there's a young female with cytopenias and marrow is showing some amount of dysplasia and your autoimmune markers are kind of plus minus, not exactly negative, not exactly positive, like DCT1 plus or something like that, how do we proceed in such situations, sir?
I mean, this is like a low-risk situation. You know, some of these are borderline, CCUS. It depends on the degree of cytopenia, whether they're transfusion dependent or not. But in the old days, Dr. Agarwal remembers this very well. We used to call this ICUS, idiopathic cytopenia of unknown significance. This happened before we had genomic and the cytogenetics. Sometimes the pathologists will struggle with, they will say, oh, there is 6% dysplasia, not enough to call it MDS. So this actually is one of the problems of this disease. By and large, Dr. Roshan, most of these patients have low-risk features and they probably need to be watched. And my suggestion to you is perhaps to repeat a bone marrow test in 2 or 3 months, and that probably will be extremely helpful here.
Thank you, sir. Thank you.
Another question that has come up, your post-transplant maintenance strategy for high-risk MDS.
This is better said than done. We, with Dr. De Lima, when he was here, published very strong data showing that this really helps these kind of patients, P53 mutated, complex cytogenetics, people that go to transplant with a suboptimal response and so forth. The best data is to start this with HMA in general as soon as possible. Let's say day 30, day 40, day 50, things like that. The reality, as you very well know, sometimes these patients are very sick post-transplant. They have the GBH, they have diarrhea, they have this, they have that. And many times, my colleagues, I'm not a transplant doctor, but my colleagues in the transplant department, they struggle with this. And they are not able really to start therapy because maybe the counts have not recovered or maybe there is some GBH. So unfortunately, it's difficult to really institute. And that's why some of these trials actually have not worked out that well, because it's very difficult to kind of randomize HMA or not, because you cannot sometimes predict how they're going to behave. In general, I push for HMA post-transplant therapy, particularly, again, in this group of patients with the bad chromosomes, multiple mutations, P53. I really try to do my best to maintain them. Indeed, there was a very nice, the presentation that I had in the talk from the APR, that was very illuminating how, when they put the APR with the ASA, those patients that had a molecular response before the transplant did better in terms of the survival. I think that's a very important concept, but it's sometimes clinically difficult to do.
Thank you. Another question that has come is, in continuation with this question, what would be the dose of azacitidine?
You will use a lower dose. So the study of De Lima, I think, used an awkward dose of the azacitidine. I don't remember, for 4 days, something like this. I think you just use an attenuated dose, and like if you're going to use the azacitidine, you could do 3 to 5 days, 50 milligrams per square meter. I don't think they tolerate 7 days, 75 milligrams per meter square. So it will depend on the degree of cytopenia and so forth. But in general, I will use an attenuated dose. And with the cytarabine, I think a 3-day schedule probably will be good, 20 milligrams per meter square. Give me 1 second, please. Sorry about this. Thank you.
Not at all, sir. One last question is, any specific cutoff for TP53 mutation level expression for APR246 eligibility in the trials?
I don't know who's asking this question, but this is a phenomenal question. It's a very good question. This question I had myself. And I think the colleague is asking this because the question is, are all the P53 the same? And I think he or she is right. And I'm part of the studies. And I told the sponsor, we're making a mistake here, because if you have a P53 with a very low allelic fraction, 2%, 3%, and you are diploid, is this really bad? Probably not. Whereas if you have Li-Fraumeni syndrome and 50% of your cells are P53, that's probably really bad. So those studies actually did not account for the VIF of the mutation. And of course, some of these mutations with the P53, the codon mutated, are not that bad. You are familiar with the IWG paper, the monoallelic versus biallelic P53. So there is some complexity there. And now, even myself, we're putting all the P53 in the same basket. And the reality is that probably this is a mistake, that maybe low BIF with good chromosomes is as good as anything else. Whereas if you have high BIF, biallelic mutations, that's very bad. That's a fantastic question. I don't know why he or she is asking this, but this person is into something very important. And indeed, at this APR meeting, there was a suggestion that the drug benefit, I was right actually, because I told that to the sponsor, there was a suggestion, if you follow the slides, that maybe those with higher P53 did a little bit better. That is what you expect.
Any other question from anybody? Okay, so sir, thank you very much.
My honor, sir.
Take it.
I wish you the best, everybody, in these times.
Thank you for making us wiser. Thank you. Bye-bye.
Thank you, sir. Bye.
And all of you, thank you. See you tomorrow. In case we have Emcure with us. Dr. Arvind, are you there?
No, sir, he is not there.
Okay, then thank you and good night to everybody.
Thank you, sir.
Thank you.
Thank you, sir. Thank you.